early, so everybody, you can just hear us chin wag. Paul, are you happy hosting the poll? Yeah.
Yep, absolutely. So Greg, if you get your slides up and ready.
And I'll do an intro.
The slides, you have them?
Are we working just? Yeah, are we just not working from the poll?
Is it just poll based? Sorry.
Yes.
Yeah.
Okay.
It's just poll based.
Not a problem. I'll be in charge. So just let me know when you want the poll to run, and I'll click go.
Greg, did you just really panic then when he said, "Where are your slides?" Oh, I love it. So, guys, please meet a very dear friend of mine. This is Greg McGarrell. He runs a company called Nupsala. He is also the owner of Nupsala Musculoskeletal Clinic based in Melton Mowbray. I met him many years ago, right at the start of canine arthritis management. And I am very proud to say this man has had faith in what we've been doing, and he's supported me the whole time. So for the last 9 years, he's had my back, and I just want to have the opportunity to say thank you. He's here to come and talk to us about intra-articular approaches. It's something that I'm not hugely confident. So I'm here as his student to pose him questions and basically make this poll a little bit more dynamic, a little bit more of a mentor like student having a discussion. Please do not be fearful of the Q&A box. Use it. This is your opportunity to ask those questions. So Greg, just a quick intro about yourself so they know something about you before we crack on.
Okay, yeah, thank you everybody for joining me this evening. As we've already had mentioned, my background with Nupsala and Nupsala MSK. By training, I'm an orthopedic tissue engineer. I've been involved in this area of veterinary medicine. I hate using the word regenerative medicine. That's so cliche these days. But it all goes back to where I started getting involved in this area of, let's call it intra-articulars, or using non-traditional medicines. Back in 2000, when I was at the RVC, the Royal Veterinary College, with the orthopedic team on equine, back then with the likes of Roger Smith, Alan Goodship, looking at ways of tackling the early stages of musculoskeletal disease in horses. It's a fantastic area to look at because, for one thing, it has a huge driver. You know, horses get early stage musculoskeletal disease, whether that be tenderness, joint, whatever, and that leads to loss of use, loss of function, unfortunately, loss of revenue. So money is always a big driver here, not just the comfort of the patient, but, you know, keeping your Ferrari at optimal drove it. So nearly 24 years ago now, Christ, we're all getting older. So 24 years ago, we started looking at other ways of treating what is a progressive degenerative disease in musculoskeletal. And that's been the trials and tribulations for the last 24 years for me. Understanding it, teaching it, supporting it, looking at an awful lot of technology coming to market that is appropriate and a lot that is not appropriate. And it has been a minefield. It really has for the last 24 years, trying to figure out where, when, and how to use these different treatment modalities, especially when we're going into specific targeted area. I know we're talking about intra-articular today, but it's when we steer away from a systemic approach, which I think a lot of the treatments have been discussed at the last 4 days have been around a systemic application or administration. Now we're into the world of targeted local administration. How do we go about that? What do we use? Is there a space where we look at traditional medicines versus the likes of the biologics and even some of the more exciting stuff that's coming on the horizon? So yeah, that's kind of where what I've been doing.
No. And there's I think just before we step in, I think something that really needs to be mentioned is arthritis isn't black and white. Well, it is, you've got it or you haven't got it kind of thing, but the spectrum is vast. And I recently shared an image from Richard Meeson about imaging modalities that are going to be able for us to detect earlier and earlier and earlier osteoarthritic changes. So going right back to like synovitic changes, so that we can catch it early, because our mainstay, which is still radiography, is really quite late. And branching, really, basically broaching onto end stage. So just give people a very quick overview about what arthritis is so they can understand that these treatments have potential different stages rather than just, oh, it's PRP or it's just stem cells.
No, you're quite right. You started on the fact that it starts with changes, subtle changes within the whole joint environment. Okay, when you look at all the structures that are involved in the joint, from tendon, ligament, the synovial membrane, the actual joint capsule itself, the quality of the joint fluid, the articular surface, the subchondral bone, you're talking a melee of tissues here that all start to get affected. And what's interesting, I'll harp back to it, is a lot of my early work was in horses because of this driver. Early joint disease to horse owners, they have a title for it. It's really fascinating. They call it poor performance. All right.
Mm-hmm.
Now, in the world of small animal, that doesn't exist.
We don't see it in cats. We don't have poor performance.
You would never see it. I don't think you'd even see it. Well, you would see it if you're at top level agility. I've seen some of the lectures that Sherman Knapp delivers, some of the agility dogs that he's treating over in the US, and they are so tuned into changes in the dog's performance or behavior that they know it's not a behavioral issue, it's an adaptive issue. Now, the slightest amount of pain or discomfort in the joint, you'll get an adaptive change. Now, again, in equine medicine, we call it an adaptive gait. All right, so this is a quadruped animal, so very easy to move a weight shifting exercise that the patient will go through because it's feeling minor discomfort in that joint. And what we're looking at here is early synovitis, early changes within the joint, and the synovial tissue becomes inflamed, and because it's inflamed, it's a sore, so you'll get a lameness. But it's such a subtle lameness because it's a quadruped animal. I can shift my weight slightly, but I won't be able to jump 160. I'm now knocking poles at 160. I'm now only jumping at 150. And equine vets are tuned into that to the point where they'll go, okay, what have we got going on here? Is this the tip of the beginning? So we start to look at that. And this is where equine vets routinely would do a very thorough lameness investigation, understand the joint that's being affected. And what they're treating is nothing that you would see on radiograph, nothing you would see on any type of CT or MRI imaging. You're looking at changes within the joint that lead them to understand that this is the beginning. So again, great analogy. If we look at equine medicine, in the case of horses, and I get this asked all the time from owner talks that I give, how do I stop tendon disease or how do I stop joint disease in a horse? Because it's a big thing for everybody. And my answer is stop riding. Stop using the horse the way you're using it, because it's not supposed to do that. All right. But what you've got is an outcome because the horse hasn't evolved, and you're getting changes within the joint, which are because of the degenerative cumulative fatigue that the soft tissues are going through. And if you hark back to, cumulative fatigue also brings about inflammation. Inflammation brings about destruction. Destruction brings out changes. Changes, we have adaptation. On it goes again. So the early part of osteoarthritis is or can be things which build up. So you're looking at that cumulative fatigue damage or cumulative damage, whether the dog or the cat or the horse or the person, overweight, environmental, breed, all of these factors start to come in, that the joint is just doing its damnedest to adapt, to change. And unfortunately, if the balance is incorrect and we're getting more inflammatory to repair, to an ability just to cope with what's being demanded of the joint, that chronic build up and changes starts to happen. So if we looked at a grading 1 to even 10, you could there is no uniform grading, but let's have an easy one, 1 to 10. If we start to see minor changes on radiograph or other imaging modality, that would probably be at about a 5.
Exactly.
All right. And there is this whole host of changes that go on. Now, the other thing that you've got to imagine is that whilst the joint is changing, it's probably not just a single joint. We could have multiple joints. And with the quadruped animal, because it is very good at adapting, this adaptive gait. And so I'm going to throw something in here at the moment. We see it in equine. I haven't really got to it in small animal yet. An animal that shows signs of lameness doesn't necessarily mean that it's in pain.
Okay.
Because they can have an adaptive gait.
Mm-hmm.
And that's because, yes, it hurt for a while. I will now shift the way that I walk or trot, especially horses when I get to canter, but trot is a very difficult gait, is that I can adapt my gait so that I'm not in pain. And sometimes you have that initial burst of pain linked to the acute synovitis or even a spell of chronic synovitis, and that gait will change. Now, the joint will repair because it's not being loaded as much as it was previously, and perhaps the owner is a little bit more careful with it. But the adaptive gait can last longer. And this is where behavior comes in, or training, or physio, or all the other modalities that kind of says to the brain, you can use it again.
Mm.
All right. So it's another one to consider, adaptive. And we go back to the first 5 phases of OA is that adaptive situation. The patient is learning to live with it, learning to cope with it. How can I change my gait, change what I do, guard, all these things leading up to the point where you can see more of the iceberg. And this is where it's then easier to diagnose. But the point that you diagnose it, even if you diagnose it as stage 5, how long has it been going on?
And I think that's what a lot of people
it's
don't
not a 5 minute.
realize.
It's a massive, it affects everything. And it really does affect everything. And the thing which I come to in this area is it is not a quick fix.
Well, it's not
it
a
really
fix,
is.
Greg.
Well, no, there is. Okay, let's agree. There is no fix. Yeah, there is no fix. Although everybody seems to think there is a quick fix, or there is a golden tablet or a golden injection that boom, I'm done. I can get on with my next patient.
Yeah,
there isn't, because all we've got is at the point that we catch it, we have to deal with what I call the destabilized patient.
Yeah,
and there's a lot that we have to do to bring a destabilized patient into a stabilized patient. And that bit in the middle isn't quick. It's quite frustrating. It's frustrating for the vets. It's frustrating for all the professionals working on it, and very frustrating for the owner, because they do think there is a quick fix to this.
Yeah.
We cannot reverse that.
Because I'm just trying to, me and you can talk about this for hours, and we do talk about it for hours. Just try, I guess I'm trying to push you in the corner to demonstrate to the people that are listening that there's a lot going on in that joint. So when people talk about, I'm just going to put stem cells in, well, is it the right time for stem cells? Am I going to just put PRP in? Oh, is it the right environment to put PRP? And I think what you taught me many years ago was that concept that it's a changing environment, and we are not at the position yet to really know what goes when. We have a better idea. And that's what you're here to kind of start illustrating to people, is it isn't a recipe. We haven't got that structure yet. Is that fair to say?
It is. And I don't want to pour water on the fire. But when I teach this, quite often I'm faced with I will now teach you more about what you don't know than what you're going to know.
Yeah.
Okay. And like I said, I've had sort of nearly 24 years experience of technology coming to market. And yes, it's exciting. It's got a buzz. And unfortunately, somebody's got to make a financial return out of it. So they might be pushing it a little bit more than they hope to. And everyone's trying to get on this rat race. But it's engineering, which is what I love. I love tissue engineering. And I have a huge tool chest of things that I can use. Now, I cannot use a hammer to drive a screw in. And that's what people, and I heard this at a talk in America many years ago, especially when it comes to articular medicine. Everybody just wants the hammer. And they're trying to drive screws in with it. And it's not appropriate. Yeah, you can do it, but it's not the best tool to use. No. So we've got to look at the status of the joint that you might be injecting. What is going on? The other question that I ask any practitioner who's going to inject into the joint, what is it you hope to achieve? Do you have that in your mind? So do you have a sort of a biological 3-4D image of what's going on inside that joint. What is happening at a cellular level? What is going on there? And your choice of medication going into that joint, what is it you hope to achieve at that point?
Mm.
How are you going to measure the outcome?
Mm.
How long will it last? When do you use the next intervention?
Mm.
So there's an awful lot that needs to be considered before we just
It is. Yeah, exactly. And I think what we're hoping to do in the next few questions is basically, it's not to scare people. I really don't want people scared of it. I just want people to not fall into the trap of thinking it's a one-stop shop that you can buy one approach and you can put it in every joint without consideration.
I think my take-home message for everybody at the end of this little session, and what's probably happened over the last 4 days, is there is a lot that can be done, an awful lot that can be done to manage the OA patient, dog, cat, horse, human. There's a lot that can be done. Having a basic understanding of when to use these different tools can lead to an amazing outcome. We can manage this disease. You and I and other practitioners have shown that when you get it right, there's a great success. There really is. So when we look at intra-articular, yes, we can really deliver a targeted approach to one or several joints if necessary. We can even avoid surgery, because that's the other thing we look at. Sometimes when OA gets to the end, joint replacement or, amputation or all sorts of surgery come into play. And I'm not against surgery, not at all. But for me, surgery is the last option, because once you do surgery, every other option's off the table. So sometimes by targeting the joint in a very specific way, by injecting any medication or biological, we can perhaps avoid surgery or prolong the point until surgery is required.
Okay.
So we can manage.
Well, let's crack on with the first question. And what we're going to do is got to be conscious of time, because me and Greg can prattle on. So Paul, tell us off when we're prattling. Launch the first question, and then we can just have a little discussion after each one, and we'll see where we get. And then we make sure that we watch the clock, because at 6 o'clock, Louise is coming on. All right. So question number 1. Intra-articular intervention medication should only be carried out by an orthopedic referral centre. What is your thoughts, people?
Wow.
Okay, that's running. So we'll just leave that for about 20 more seconds. Wait for it to slow down a little bit, because there are a lot of people selecting their option. I think you guys can see the results coming in, can't you?
Yeah.
Perfect. Okay, that seems to have headed out. So we'll end down. We'll share the results so that the attendees can see that as well. And then I'll stop that in a second.
Okay. What do you think, Greg?
Now I deliberately chose this question because it would spark a bit of discussion in this area. You could go either way on this question. And what I would look at is it should not be limited. So I'm in favor of the majority here being false. But I will say this: it does need proper tuition. Okay. And it does need guidance, and having mentored many people through joint injection in their early days of using it, there's a lot to be considered. When we do training on it, to go to a course and receive training on how to do it, typically you might be using a cadaver or models that don't replicate the true, what will be for a lot of people injecting joints, end stage disease. Right. So I think that's the first thing which I caution early GPs about going into using intra-articular medication is train again, get some coaching, get someone to shadow you and help you until you absolutely feel competent. And also you'll find certain joints can be quite taxing. To a degree, stifles are very easy, elbows can be a little bit challenging, tarsal joints a little bit more challenging, and the hip will make you sweat, especially if the patient is a little bit overweight. So, before you go diving in, get some practice in.
Yeah.
And even cadaver training is an area that will benefit you, because when it comes to that, I was going to say, to finish, it's that the sort of the grade 7s and 8s, if we use that scale before, you're not prepared for what the joint is going to feel like when you put that needle in. And you've got a anesthetized animal, you've gone to all the risk of putting the animal under a general anesthetic, or even heavy sedation to go into intra-articular. You need to be able to do it, and confidently deliver that medication, and not just guess. And I think that's where I've been with a lot of early GP training, and we've got them over that hurdle, is that I've seen them second guess that they're in the joint. And I go, "Are you really?" "Yeah, I think I am." And they were not in the joint. They were near the joint space, but they were not in the joint.
No. And I think I'm very lucky that I have people I can speak to about what to use and when, and debate the pros and the cons. And we're looking at interventions that can be quite costly. We're also looking at interventions that you're going to be doing potentially a general anesthetic, a sedation. So you've got to look at the bigger picture. Is it right for that animal? It's nice to have a debate with somebody and really have that second opinion and that experience of, actually in this dog, look at his age, look at the amount of joints that are affected, look at the soft tissue change, look at everything else. We're not going to get the results that we want in this situation. So let's invest elsewhere. So I think it's good to have a mentor. Poll number 2, Paul.
Is running.
Of the increased catabolic and pro-inflammatory mediators, which of these are the most deleterious and contribute to further disease and progression? Now, I knew this question was coming. So this is why I wanted everybody to have a bit of an idea that the situation in the joints, there's a soup of change going on. And the balance of change is really quite important. So I knew this was a question going, this was where I was pushing you, Greg. So...
But I knew people would be going down this avenue.
Much slower responses this time, I will say. So people are definitely thinking about this one.
Yeah,
it's all anonymous, we should say as well. So if you're not sure, feel free to just select an answer. We can't see what you've selected.
Yeah.
Wow.
Cool. Should we put it in? Just looking at time, we've got 23 minutes left.
Right. Okay. Well, so I'm going to close that. I can see where everyone's going. Right. We could take an hour talking about this one. All right. The situation that you've got, so it's just flashed up. The majority of people are going down the interleukin 1 and 6 pathway, which, yes, is very deleterious. But within the joint, I'm going to jump to it straight away. For me, and I'm not saying that I am right, but this is the world that I'm in, and this is where I'm going, is IL-1. Yes, everybody talks about IL-1, but IL-1 is also there for a good reason. Okay, it initiates cell turnover. And IL-1, or all the interleukins, are essentially proteins. So it's the analogy I use is they're a little bit like an offensive text message. All right. If I send you an offensive text message and you receive it, you're going to act on it. You'll respond. Okay. If you can't receive it, it doesn't matter. Okay. So within the joint space, we have natural antagonists being produced to balance IL-1, IL-6. And that's because there needs to be a certain amount of IL-1 within the joint space to initiate cell turnover. And that's because your chondrocyte that lives in its little environment, its little lacunae, needs the notice to turn over. Okay?
Yeah.
Out you go. But the problem is, it's like a little house in a compound. So you can't just leave the house. You've got to clean up after yourself. So the chondrocyte, the problem with joint is that what initiates all these changes, the bad boy here is actually the chondrocyte.
Right.
That's the problem. Now, yes, the cell receptor can receive the protein, the IL-1.
Tell them what a chondrocyte is.
That's your cartilage cell. Okay.
There you go. Good
so
job.
everybody talks about cartilage, all right? But the chondrocyte, the cartilage cell, actually only makes up a very small percentage of cartilage. So it's a very complicated environment. But the analogy that I've got used for everybody is that the little house in a compound, take your compound with you. So when the cartilage cell receives that protein for destruction, okay, it binds with the cell receptor and then initiates a destructive mechanism. But the destructive mechanism is not there just to remove the chondrocyte cell, which would be very efficient if it did. It needs to take out the lacunae, it needs to take out the whole compound it was in so that the next house and compound can come along. Well, what cleans that up?
Mm-hmm.
Well, when the cell actually initiates cell death, that's cell apoptosis, it will produce more inflammatory mediators. The nitric oxide, by the way, is what it uses to essentially kill itself.
Mm-hmm.
All right. But the biggest deleterious thing is it produces MMPs, matrix metalloproteases,
Mm-hmm.
3, 9, and 13 in particular. And they're used to clean out that compound.
Mm-hmm.
But here lies the problem. MMPs, they're like Pac-Man to soft tissue. They unlike the offensive text message interleukin, if I don't receive it, it doesn't matter. So we can actually use different targeted approach to turn off your cell phone, to turn off cell receptors. We can actually use other antagonist proteins to bind to the cell receptors to deny IL-1 action. So it doesn't matter. But MMPs carry on chomp, 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 chomp. And their favorite food after they've cleaned out the compound is synovial tissue.
Right. So they're a massive driver for synovitis.
Synovitis. Now, here's the sting in this. When we look at increasing IL-1 levels, interleukin levels, okay, this all happens retrospectively. So as it climbs, we have a production of the antagonist proteins to reverse that.
Mm-hmm.
Where do they come from? Well, they certainly don't get produced down the cartilage. It comes from the synovium. So within and it's the first layer of cells, it's called the intima layer, and there are 2 intima cells, alpha and beta intima cells. Now, the beta intima cell is a fantastic little synoviocyte because it receives synovial fluid and it analyzes it. Okay, so it's a constant back and forth, back and forth. It produces the next amount of synovial fluid and it produces proteins in response to what it's reading.
Mm-hmm.
So it really is, and it's almost like the placenta of the joint space.
Mm-hmm.
It's a beautiful mother cell. It takes care, it does everything, it cleans, it nurtures, it protects, and it feeds. And it's the thing that the MMPs like to eat.
Right. Well, we're going to move on to question number 3, because I think that to me is very good at demonstrating that there's a lot more going on, because there is a real kind of like, oh, the synovial fluid changes and the bone just gets thicker and the joint capsule thickens. And actually, when you look at the nitty gritty of what is happening more on a cellular protein basis, we start opening the box of what can we do with this? And the interventions that are available for osteoarthritis management are expanding the knowledge behind it. So question 3, Paul.
Yep, that's up and running.
Arthrocentesis is considered to be a beneficial step in the stabilization and management of osteoarthritis. So arthrocentesis is when you're actually extracting synovial fluid from the joint. It can be diagnostic or it could potentially be therapeutic. What do you feel?
Interesting mix so far.
Yeah.
People
I knew this would have a very different
opinion. Yeah. So getting close to 40% of people. Feel free to, as we mentioned earlier, it's totally anonymous. So feel free to select an option.
So again, a bit of a thought put in this question, and I'll throw it in, is that to perform arthrocentesis, one has to accurately place the needle inside the joint. And I think this is where, and I've had it sometimes, people are they're happy to do arthrocentesis, but they're not happy to do a joint injection. I've actually had that before.
Just explain the difference though, Greg. So some people that they're going to be canine professionals and other allied. What's the difference between arthrocentesis and the joint injection?
Well, the arthrocentesis is placing the needle inside the joint and removing the joint fluid, okay, versus injecting something into it.
Yeah.
Now, when we talk about arthrocentesis, and actually when we talk about this and lecture on it, I often say that the arthrocentesis can actually be a form of treatment in some respects, especially in the stabilization stage, because the joint fluid itself, the joint is trying very hard to balance the increased inflammatory mediators. Remove them. So you can remove a portion of joint fluid. That will actually, first of all, encourage new joint fluid to be produced, and it does so over a period of time. It removes some of those inflammatory mediators, and it can also be sent away for analysis to give you a bit of baseline on what cells are in the joint fluid. So for me, arthrocentesis in that stabilization period, and again, often when we're going to administer the first intra-articular medication, we would always prove positive placement of the needle into the joint by having a flash of synovial fluid.
Yeah.
If you're in, don't just go for the flash, take some out. Take some more out.
So would you say it's also going to be offering immediate clinical benefit pain-wise? Because we're at the Chronic Pain Symposium.
Well, one of the things which we know where pain comes from is those nociceptors and mechanoreceptors within the joint capsule. And quite often within a diseased joint, we get an overproduction of synovial fluid. That can lead to joint effusion. So the joint capsule is being stretched, and that itself is painful. So removing that, especially before we go injecting something else, because we can distend the joint even further, and that could end up with a bit more painful joint. So, in a layman term, deflating the joint is going to have an immediate, oh, that's a bit better. You removed all that increased fluid. Even at a very rudimentary level, you can assess what the quality of the joint fluid is like. We're after this straw-colored, tacky, oily joint fluid. That's what we're after. If it's really, really clear and really runny, and there's no tackiness to it, then really we just have an abundance of fluid. Okay, let's remove that, and let's help the joint get on with producing better synovial fluid and removing some of those mediators, which, as we've discussed in the past, have a looping effect. All right, so this whole thing where IL-1 binds, chondrocyte releases, the other inflammatory mediators, and that's what triggers this cyclical effect. IL-1 loops every 14 days, TNF-alpha loops every 28 days. So by removing that burden of inflammatory mediators, brings the wave down. And we haven't got time to discuss the wave, but
I remember the wave.
Yeah, the cumulative wave gets bigger, and you bring physics into this. If something is out of control, the wave gets bigger and bigger and bigger until it becomes clinical. If I can reduce that burden or reduce the power of the wave, then the wave will build back up again, but it could take several weeks, several months to build back up again.
Okay, I'm just going to jump in. What about saline flush?
What's the difference between scoping a joint?
Well, this is it, because I can remember we talked about this a few years back. We haven't touched this subject for at least 3 years. Yeah. Is there anything to suggest benefits of saline flush in addition? So you've tapped it, and you're going to tap it both sides, and you're going to flush it. Has anybody done any studies to show that is better than just an arthrocentesis on its own?
I don't know if there's any studies, I have to admit, but I've heard several surgeons talk about it, both in human and veterinary. It seems to be something which is quite in vogue at the moment in Germany. So they will flush joints prior to, especially in human medicine, they will flush joints prior to a biologic being put in. But quite often, they'll scope the joint. So when we think about it, we go in and put a camera inside the joint to look around, perhaps even clean something up or do what we need to do. Doing so will flush the joint, because that's what the arthroscopy camera is going to do, and you're going to put fluid in. And patients always recover well after a scoping. If you go back to horses, they'll stand straight up. They haven't got a problem with it. The joint isn't dry. It's not like you're leaving the engine without oil in it.
Yeah.
The synovial fluid does get produced.
I do remember you telling me that having a baseline inflammatory state can trigger certain biologicals that you put in to kickstart them into action. So again, you need to know what you're trying to achieve, don't you?
Yeah.
There you go. Poll number, is it 4 already? We've got 10
Yeah,
minutes.
Yeah, we haven't got much time.
No. Which of the agent descriptions are incorrect? Betamethasone esters have no deleterious effects. Triamcinolone is chondroprotective. Methylprednisolone has no deleterious effects. Which of the agent descriptions are incorrect?
This is fascinating.
Should we go for it? Do you want to start explaining? Start off what you mean by chondroprotective first. No, first of all, for people that don't know, what are these? These are steroids. Okay.
They're steroids. And we didn't really have the time to go into, in case anybody was sort of waiting for the questions or the slides on which biologic to use, that would be another 4-day course. But, this is, traditional steroid. Okay. So what we're trying to do here is to stop inflammation, block prostaglandin, get in and do it. And, in a destabilized joint, this works. Now, for equine, if there's any equine surgeons online, or if you have had horses treated, the use of corticosteroids intra-articular is routine. Okay. It is done absolutely every single day. If you're an equine vet, be prepared to be injecting joints on a daily, morning and afternoon basis, because this is your bread and butter. And the most used drug is triamcinolone. So quite often triamcinolone is used in conjunction with HA, although there's been some recent studies in the US that actually shows that the HA component of it doesn't really have much effect. It's more like a carrier for the triamcinolone.
What's HA?
Sorry, hyaluronic acid.
Thank you.
So we know that the triamcinolone is chondroprotective. It doesn't do anything deleterious to the chondrocyte, whereas the methylprednisolone does. Yes. Okay, so the answer here is methylprednisolone does have a deleterious. So the third one is the one that's incorrect. The first two are correct. So betamethasone is not deleterious. We tend not to go down the betamethasone route because of cost. Believe it or not, it's a decent corticosteroid, but triamcinolone is cheap as chips. All right, and it's very, very effective.
Putting it into a quick context of first opinion practice, there's always those memes of nothing should leave this planet without steroids, and we don't seem to apply that to joints. But it has been considered in the past that end stage joints, to buy a bit more time, pop a steroid in. Where do we sit with that now? Is that
it can be used in the stabilization side, but I'll give you, there's always a balance here. So the mode of mechanism that the likes of a corticosteroid, likes of triamcinolone, is going to use in blocking prostaglandin, it also blocks in the same capacity fibroblast growth. Now, that's your sign of your tissue. That's your intima cells. So we know they're fibroblasts of origin. So in one respect, you're treating the synovitis. We know that the synovial membrane is struggling to get on top of this, and you're going to have loss of tissue. Okay, and the tissue is trying to regenerate. It's trying to grow back. Now, interestingly, here, one of the problems it's got, that soft tissue trying to grow back, is the synovial fluid itself. Synovial fluid is tissue growth inhibiting. So it's battling with the fact that the tissue can't grow in the presence of synovial fluid. So we have that as an added problem. But the steroid that you just put in just shut it down. It's like no growth is going to happen, at least for 56 days, whilst this is still active. But it is very, very effective at shutting down the inflammatory situation. So in a destabilized patient, it works. Steroids work.
So would you say it's a palliative option? So when we're looking at, actually, we're running out of options, we're looking at treatment to improve quality of life, and we've got a really two awful elbows, and that dog is just, and the owner's not ready to let go.
Ask any equine vet. They'll be reaching for the TA immediately.
Fine.
Because they know it works. Right. We also, we've got to be careful how we use it in horses, because it's a controlled substance. We can't compete on it. We've also got to be careful of other side effects. In the horse, it's going to be things like laminitis. But the other thing you've got to appreciate here is if there is any other condition, renal failure or other things that might be affected, liver, is that whatever you put inside the joint doesn't just stay in the joint.
Yeah.
It goes systemic. So be very careful that we're not going to kick something else at the same time.
Yeah.
But when we come back to what can go in the joint, if the animal's anesthetized, we know we've got OA. It is very painful. There is nothing wrong with an immediate course of steroid, because it's probably less than £1 worth of drug that can be administered to the patient to get it on the path to management.
Fine. And just humor me, because I can remember when you told me about the synovial fluid being, as you say, tissue limiting. Where do osteophytes form, Greg? Because I can remember having only ever seen x-rays and surgically, and people will just see the gnarliness, the gnarly joints. Where are those osteophytes? Where are they hanging out?
Well, this is, well, you've kind of answered that. Okay. Why don't they grow inside the joint?
Yeah. I didn't know this. He told me this. I was like, oh yeah. Very fascinating.
Remodeling. Absolutely, we get remodeling, subchondral bone remodels and everything. But that whole gnarly is all periarticular.
Yes.
But the tissue we're trying to, am I going to line up another question? I don't know. But when we look at what we're trying to save, so I'll be straight with it. I'm past trying to save cartilage. Okay. My world, I'm trying to save the synovial membrane.
Yes.
I'm trying to save the mother of the joint, the nurturer, the healer. Okay, cartilage will keep on growing very, very slowly. It's like a glacier, the speed it grows. But the synovial tissue is what I'm trying to save the most.
Yeah. Well, we've got 4 minutes, so we've got one more question. Can we do that in 4 minutes and then wrap up?
Go, quick. Yeah, go.
Let's do it. The biggest challenge in using intra-articular drug delivery are...
I forgot this one.
Okay, come on, guys. Let's do this. We've got 3 minutes.
Good.
The biggest challenge in using intra-articular drug delivery are...
So if anyone can't see the full answer there, to make a selection, if you hover your mouse over each one, you should be able to read it in full.
So I'll start with saying any one of these is the challenge. Okay. And not one of them is a wrong answer.
No.
But I guess where I come from is the lack of published evidence showing long-term efficacy. Because it's not just one thing. We might have one drug or one medication that has been shown to have efficacy, but we know there isn't one drug that can be used all the time.
Yeah.
So what we haven't looked at is, we started with, say, corticosteroid, then we moved on to a specific biological. It could be something like IRAP or alpha 2. These are the two biologics that are used at dealing with the inflammatory mediators. We then can move on to a PRP or a stem cell. We're not looking at how the melee of intra-articulars can be used to manage long-term management of an OA patient. A lot of the studies are very short-term. We know how they work, but no one's ever put the jigsaw together to look at a long-term management plan.
And that's a big limiting factor on many things that we do. There aren't lifetime studies. And I was actually having a conversation with somebody only this morning about when people say, should we start joint supplements when they're young? Well, we haven't got lifetime studies, so we don't know. So how can we make big statement pieces like that unless we actually follow it through in large numbers to the bitter end? Right, just because of time, I'm hoping, and my intention of asking Greg to come and chat on here is to really stimulate interest in this area, because it's a growing area. There's a lot to be learnt, but I think our current understanding in first opinion practice is here. There is the ability to be here because you have courses, don't you, Greg? There's the Veterinary Osteoarthritis Alliance that are doing courses. We've got the Veterinary Osteoarthritis. Can we say VOA? It's easier. The VOA conference is the 25th and 26th of
22nd, 23rd of May.
22nd, 23rd of May in Leicester.
That's
Of this year. It's a 2-day event where you will learn a hell of a lot more. You still have the big picture, which is what we're kind of doing today, but you're going to have more detail about intra-articular surgical approaches and much more tailored for the joint. So please be inspired to go and learn more. Greg's details are in the delegate bag, which is going to be coming out in the next couple of days. We got let down a little bit by the company there, but those details are going to be coming your way. You're in the expo. You've got your stand there. And if you can't find Greg, you can just go to nupsala.com, NUPSALA.com, and you'll be able to find him there. He's got a wealth of knowledge to share with you. And I hope this session has stimulated some interest. Thank you, Greg, for giving up your time to come and spend time with me on a Sunday afternoon. Right, guys. Hopefully you're full, and we're going to go over next to Louise. So leave this one and head on straight to the next session. Take care, guys.
Thank you very much.
Wants to do the Q&A because she's a big fan of Louise. So hopefully that'll be a really good discussion that we can have at the end. So Louise is a European and Royal College recognised specialist in veterinary anaesthesia and analgesia, and has an MSc in clinical management of pain. She's currently based at Davies Veterinary Specialists, and we are very fortunate that she's managed to make it with us today because she is on call at the hospital at the moment, and is in between surgeries. So thank you so much, Louise. We really appreciate it. She's going to be talking to us about, like I say, post-surgical pain. As we know, it's a huge drain on resources in the human sector, and Louise is going to be focusing on what we know about it in veterinary medicine and what we need to be aware of. So thank you, Louise.
Hi, good evening, everybody, and congratulations for staying this long in the marathon. You've done better than me. I've not been able to join everything, but I've really enjoyed what I have joined. And for full disclosure, I'm lucky I'm on call with a very good resident, so he's dealing with most of the stuff that is going on, but we do have quite a lot going on at the moment. So this is maybe a little bit of a hobby horse talk. Persistent or chronic post-surgical pain is something that I have quite a lot of interest in, and have done for a while. And really what we're going to talk about tonight is this a welfare problem hidden in plain sight? Or is this something that we know about in people, but probably isn't relevant to our cases? I'm going to suggest that potentially it's the former. But using what I'm going to call an evidence-informed approach, thanks to Matt and Carl yesterday morning, I'm going to leverage some of the human data and suggest that maybe it is something that we need to think about. And in thinking about it, we potentially need to do something about it. So learning objectives, that sounds a little bit heavy for like 7 o'clock UK time on the Sunday night, but I just want to go through what is persistent post-surgical pain. There is a very clear definition in human practice. How does it arise? How much of a problem is it? And we only have human data. When is it likely to occur? And in the context of knowing that information, what about our veterinary cases? And ultimately, what are we going to do about it? How can we manage it? Can we manage it? So hopefully that'll be the next 40 minutes or so. So I enabled my the most technology I can manage, and we have some nice QR codes which should scan off the screen. Basically, there's QR codes through most of the references that I'm going to use so that you can keep them and we don't have to keep repeating URLs into the chat. This is a really good review and it's very easy to read, and it's called Chronic Post-Surgical Pain, Update on Incidence, Risk Factors, Preventative Treatment Options. And one of the authors is very, very well respected in this area. She is a leading figure in this area, and it is one of the most up-to-date things that you can read about persistent post-surgical pain in people, if you're interested in that. The nomenclature, chronic or persistent, it's basically the same definition. It's just used slightly differently in different publications. It's one of the most frequent complications after surgery, and it has an important negative impact on the patient's quality of life. And as was mentioned in the introduction to this talk, it constitutes a significant economic and healthcare burden. The mean incidence of chronic pain at 6 to 12 months after surgery is 20 to 30%, with a slight decrease over time, and we'll caveat that as we go forward. The incidence differs a lot depending on the type of surgery, and we think it's going to remain a challenge with the increasing number of surgeries going on worldwide. So if we look at obesity, inflammatory disease, and increased life expectancy globally, they've resulted in an increased volume of surgeries, and things which are considered routine, if you listen to the media, hip and knee arthroplasty, are actually associated with a high risk of chronic or persistent post-surgical pain. I think just whilst we're kind of in this discussing that we have so much data from people, we do need to be aware that this is a fairly new, if you like, problem. It's definitely not a new problem, but it's something that has a fairly new data set in terms of medicine. The first report of this was actually in 1998. From a team from Dundee in Scotland. Scotland is at the forefront of all things medicine, and I'm sure Sheila Robertson would agree with that. And this was from an anaesthetist who was looking retrospectively at the people who were attending a chronic pain clinic and realizing what he called the antecedent effect of surgery. So how many of the chronic pain patients had surgery previously, and how many of them were deemed to have had successful surgery by the surgeon, but they had persistent post-surgical pain. So that was 1998. And I remember going back to when I was doing my residency, which is a long time ago, this was something that was just being talked about when I did my FRCA, which is the human course in the UK, with the, if you like, the human anaesthetists. They were beginning to discuss persistent post-surgical pain. So the trajectory data-wise has been huge, upward, and massive amounts of data. So I don't think we can be too critical of ourselves in have not really piggybacking onto that. But whilst we piggyback onto the back of everything else that's been done in human medicine, be it interventional, pain management, all the different drugs, we've been a bit slow on this one. So what is persistent post-surgical pain? The difference, the definition, it's either chronic post-surgical or post-surgically traumatic pain, was standardized in what's called the International Classification of Diseases 11th revision, which is basically now generally called ICD-11. And what this means is that anybody who is presenting to a healthcare situation should ostensibly have a diagnosis, and being able to get a diagnosis allows us to use the data in a much more effective manner. So if we know that a patient is diagnosed with persistent post-surgical pain, that number then sits within a lot of data sets so that we can use it going forward. But what is it? Pain that develops or increases in intensity after a surgical procedure or a tissue injury. Pain that persists beyond the healing process, and that's generally defined as being greater than or equal to 3 months after the triggering event. And it's either at the surgical area or area of injury or projected onto the innervation area of a nerve. So a nerve in that area or to a related to a dermatome. So other causes of pain post-surgical, i.e. pre-existing pain condition, infection, malignancy, direct surgical complication, have to have been excluded for something to fit within this definition. And chronic post-surgical pain can often show characteristics of neuropathic pain. So those of you who listened to Claire Rusbridge, Sarah Heath this morning, Neuropathic pain we will briefly revise, but ostensibly it has different characteristics from nociceptive or even nociplastic pain. And it has to be distinguished between tissue trauma arising from a controlled procedure in the delivery of healthcare, i.e. that's why it's post-surgical pain, and other forms of uncontrolled accidental damage. So persistent pain after a road traffic accident would not be considered to be persistent post-surgical pain. And as I said earlier, in people, the inclusion in ICD-11 is a major step because it just allows better data handling. So if we know what it is, where does it come from? How does it arise? If you like, what's the pathophysiology? So remember, and you've been on this 20 odd hours, so you should know this, all pain is not the same. We need to think about mechanisms and contributors. Once we know about mechanisms and contributors, we can think about development and think about the relevance to management, because if we know where the pain or how and where the pain arises from, we can think about how we might be able to manage it if it's there. And we also, potentially more importantly, can think about how we may actually be able to prevent it, because ultimately, if we're doing surgery, particularly in our situation where we're doing surgery to animals who have no autonomy, they can't actually give informed consent. So the animal is not giving consent for what we do to them. It's important that above all, we do no harm. And whilst we may be doing surgery for the best of intentions, we need to be aware that we need to cover up that from both. We need to be thinking about pain in terms of doing no harm too. This has already been covered, but just for the benefit of revision, for those of you who are running out of caffeine, nociceptive or inflammatory pain is essentially a response to an noxious stimulus where we've got tissue damage, we've got chemical activation, we've got, if you like, an inflammatory soup within the tissue, we've got an ongoing process there. Nociplastic pain is something that is a newer type of definition, and it's where we have altered nociception, changes in CNS processing, altered pain modulation, but it doesn't actually fit with tissue damage or disease or a lesion of the somatosensory nervous system. In people, this tends to encompass the functional pain syndromes and things like fibromyalgia, some of the pelvic pain, abdominal pain syndromes that we really have not characterized in our species. I suspect as we learn more, they may well be there. But nociplastic pain is probably new to some of you and just been raised in this forum this weekend. Neuropathic pain is resultant, very clearly defined, and the definition has changed fairly recently, but it is resultant to a lesion or disease the somatosensory nervous system, and it can include the peripheral fibers or the central neurons. And it's typified by nerve damage and ion channel changes. And depending on the disease process, you may have a primary inflammatory or nociceptive process, you may have a primarily a neuropathic process, or you may have both. And just a couple of examples are many tumors have both nociceptive and neuropathic characteristics. And something like a prolapsed disc with nerve root compression, one of the cases that we've just been dealing with, you have multiple sources of pain. You've got soft tissues, you've got disc, you've got nerve root. So you're going to have both nociceptive and neuropathic pain. So characterizing the mechanism of pain is important. And we know that in persistent post-surgical pain, a lot of the cases show neuropathic characteristics. And this has been covered already, but just as a revision, we've got these two different mechanisms, if you like, that are going to contribute inflammation and nerve damage. And that's just a really nice basic illustration of the difference between the inflammatory mediators and nerve injury. So greater than 40% of patients with moderate to severe persistent post-surgical pain, and that definition is greater than 5 out of 10 on a visual analog scale. So greater than or equal to 5 out of 10 on a visual analog scale. And more than 40% of them have neuropathic symptoms that interfere with daily activities. Remember, neuropathic symptoms is important. Symptom is self-report. We don't have the ability to get obvious verbal self-report from our patients, so that's something to be very aware of. And many of these patients, as we go back to the origins of the studies on persistent post-surgical pain, the surgeon thought they had fixed, they had very few clinical signs, and clinical examination may not be revealing. So remember that this is not something that is necessarily easy to diagnose in humans. It's reliant on self-report. Potentially, if we think forward, it's going to be even harder to diagnose in our patients. And it's likely resultant to nerve damage during surgical intervention. So if you just remember that one fact, nerve damage during surgical intervention is a big contributor to persistent post-surgical pain. We can think about how we might be able to characterize and manage it. So ostensibly, persistent post-surgical pain is a treatment side effect. We're doing surgery for the right reasons, one would hope, but we may well have side effects because of what we do. You insult nerves with something sharp or something hot or any other mechanism that is involved in surgery, and they don't like it as the bottom line, and you will get potentially ramifications going forward. So just as a quick synopsis, we know from what Sarah Heath and Claire Rushbridge talked about this morning, we've got a loss or interruption of physiological inputs if we've got damage to the somatosensory nervous system. So, for example, if you think about what happens during a limb amputation, we've got changes there. We've got then resultant ion channel changes, particularly sodium and calcium channels, but particularly sodium channels. The nerves, if you remember that we need sodium channels are fundamental to nerve conduction. And if you damage the nerves, you then get an accumulation of sodium channels and you get ectopic activity. So that can be present as a neuroma, or you don't even actually have to have a neuroma. You can just get these sodium channels accumulating, and basically the nerve fires in the absence of stimulus. So what might be termed into what people call the spontaneous pain. The nerve will fire despite there actually being no input into it. So this is this ectopic activity. Calcium channels are also fundamental. Some people call them the gatekeepers, and they tend to mitigate and manage the rate of change of conduction within the spinal cord. So if we think about what happens during surgery, for example, in the thoracotomy, you get damage to the intercostal nerve, for example, and those damaged fibers will then generate what we call stimulus-independent activity, which can cause spontaneous pain. And in people, this is characterized often as a burning pain, and a great description, which you don't hear used in common English, a lancinating pain, a really sharp stabbing type pain. So if you ever think about it in your patients, animals that are vocalizing, jumping, suddenly turning around, that's likely because they've got a sudden, if you like, unprovoked or stimulus-independent pain. Get heat and cold sensitivity, they can get numbness, you get dysesthesias and allodynia. Allodynia essentially being where something that should not be painful is now painful. And in people, quantitative sensory testing may well be used to characterize this, these loss and gains, if you like. And James, who was talking earlier, has done James Hunt, quite a lot of work on QST in dogs, and there are other groups doing work on that, but it's not something that we're able to really leverage in the clinic as yet. But essentially, if you can take home that we've damaged the somatosensory nervous system, we've damaged the nerves during surgery, and they don't like that, that's probably the biggest learning point. So how much of a problem is it? Why are we actually worried about it? Well, we do have this really good human data. So if we look at this, and I've highlighted this for a reason, just because it's something that we do quite a lot of. if we look at amputation, the incidence of persistent post-surgical pain in people is between 30 and 85%. And the incidence of severe, which is greater than 5 out of 10, is 5 to 10%. And if we think about that at 12 months, that 75% with a lower limb amputation. So that's fairly big numbers. And it's, you know, there's a significant, if you like, incidence there. If we also scroll down that and look at thoracotomy, we've got an incidence of severe persistent post-surgical pain of around about 10%. And we've got an overall incidence of 40%. And interestingly, even small things like hernia surgery, you've got an incidence of severe persistent post-surgical pain of 2 to 4%. Pretty minor surgery if you think about it, but you do have still get persistent post-surgical pain. So these are things that we are going to be doing to our patients. It's just something to be aware of. When is it likely to occur? Can we characterize which patients are going to see this in? We know it happens, but how do we know which patients it's going to happen to? If we say it occurs in 20 to 40% of arthroplasties, which of those arthroplasty cases are we actually going to see it in? Do we have any idea? Can we define it? So there are a lot of risk factors that have been reported or even like demonstrated to be relevant to people. And some of these may not be relevant at all to our patients, but I think it's important to think about them. So younger people, is that psychological, or is it because the younger you are, the more plastic your entire somatosensory nervous system is? Being female, being obese, genetic component, psychosocial factors. The psychosocial factors arguably are potentially much less important in our patients, but there's some big stuff there that if you think about is definitely potentially relevant to our patients, given the fact that as far as we know, the nociceptive transmission system is fairly similar. There are likely to be differences in things like descending inhibition, but we do know that the degree of preceding pain, surgical factors, the amount of acute postoperative pain, and are all big players in risk factors for persistent post-surgical pain in people. So if we kind of leverage the things that we know are likely to be an issue in our patients and then look at what the evidence is in people, it will be, it might show us whether we actually have a problem or not. So if we look to start with at our patients, the evidence there, as the color gets darker, the data gets stronger. So if you look at the bottom of the circle thing there, the lighter in color, there's only a few data, and the darker in color, we've got consistent evidence. So potentially, anything in that patient stuff, it's not very strong, the evidence. The psychosocial factors, the lower education level, the previous comorbidities, the young age in adults, we just, probably potentially not relevant to our patients. But if we look at anesthesia, top right, there is some evidence that higher opioid doses are more likely to result in persistent post-surgical pain, and we'll come on to that later. And the use of local regional analgesia, spinal or preventive approaches may also have relevance, but the data is not that strong, fairly pale in color. If we look at bottom right, the rule from that is get a good surgeon. The fewer surgical complications and the shorter the duration, the better the likely outcome. So that's kind of something that we see with our surgeons. I certainly do. We've got some amazing surgeons who have very few surgical complications and operate quite rapidly. Evidence for nerve injury is there, and evidence for open versus laparoscopic surgery is there. They're all potentially factors that are relevant in our world as well as in human practice. And bottom left, pain. So preoperative pain and post-operative pain, they're a really dark red in color. There's really strong evidence that this impacts persistent post-surgical pain in human patients. And because the processing central is very similar, yes, cognitively our patients are different, but they still have changes to their affective state. I think it's not unreasonable to suggest that animals with significant preoperative pain and animals with poor postoperative pain control, i.e. they have severe acute postoperative pain, are much more likely at risk to see persistent post-surgical pain. So that makes the modifiable risk factors for veterinary patients potentially how painful they are before surgery, how painful they are after surgery, surgical complications and long surgeries. So we need to do a good job and our surgeons need to do a good job. Is that the best that we can hope for? Well, we'll look at some specific interventions going forward. So a lot of data from human practice, but what about our cases? Is this just my hobby horse? Well, it might be because I wrote an editorial on it, but is this a problem? Well, our data, which I'll go on to present, is pretty poor. But if we actually use some of the data where animals have been used as models for human pain, then actually it starts to stack up a little bit. Those working in translational research will be aware of things like the spared nerve injury model in rats, where essentially we damage a nerve to create persistent pain. Well, there you go. We know that damaging, in this case, tends to be ligation of a nerve in order to create a pain model, causes persistent pain. We also have increasing evidence that if we do surgery on younger animals, things like the husbandry things that are done on farm animals, particularly because we see that many of them have got pretty poor analgesia at that point in time, we know definitively that surgery in younger animals impacts the plasticity of the nervous system throughout life. There's really good data from multiple species, including people, to show that severe pain in neonates has lifelong impact. So potentially we've got data from, if you like, other sources that supports the fact that if we do noxious things to animals, we are going to get a long-term or potentially get a long-term effect. We haven't actually got much strong data, but the fact that people are looking at it, to me, is a really positive thing. And to my knowledge, this is the first first paper that was published in JAVMA, and it's actually an open access paper, so please have a look at it, where the use of an owner questionnaire to evaluate long-term surgical outcome and chronic pain after cranial cruciate ligament repair in dogs. And they had 253 cases. And this is going back 10 years when this was actually published. So, you know, these people were quite ahead of the curve, and that group from Finland. So what they basically used was the Helsinki Chronic Pain Index to evaluate long-term outcome and prevalence of chronic pain after surgical repair by various different means of repair for cranial cruciate ligament repair. They looked at essentially the Helsinki Chronic Pain Index, and they looked at dogs with good outcome and not and dogs with an excellent outcome, and on the overall basis, long-term chronic pain was found in about 30% of dogs after cruciate ligament repair. There's lots of issues with this study, but one of the points that is quite interesting is that the Helsinki Chronic Pain Index in dogs with good outcomes was significantly higher, i.e. worse, than in dogs with excellent outcomes. And lots of cruciate ligament surgery studies combine excellent and good outcomes, generally resulting in success rates of sort of greater than 90%. But using this study, there was a bit of an ambiguous zone with a Helsinki Chronic Pain Index between 6 and 11, which is kind of whether the dog may be either pain-free or painful on that score. If you looked at patients that had an excellent surgical outcome, had values similar to the level of healthy dogs. So whilst this is in no way perfect, because we know that these animals will be very different in terms of their preoperative pain, if we think about an animal that's had a chronic cruciate ligament repair versus one that's, chronic cruciate ligament disease, and maybe already has a degree of OA, compared to one that trashed its cruciate 2 days ago jumping over something, the participants are going to be slightly different. And we also know that different types of cruciate surgery will mitigate the development of stifle osteoarthritis in different manners and to different levels. And we know that TPLO, despite potentially being the best of those strategies, is still not going to be perfect depending on what's going on in the joint already. What this is just showing us that surgical success, a good surgical outcome, does not mean that the patient will be pain-free in the long term. And I think that's something that we need to be just aware of. And this is a more recent study showing that the influence of the choice of preemptive analgesia on long-term post-surgical pain after TPLO this has not shown a difference. And in this study, 41% of dogs that were evaluated again with a Helsinki Chronic Pain Index showed values that were compatible with persistent post-surgical pain, regardless of the type of preemptive analgesia. Increased body weight was a negative prognostic indicator for persistent post-surgical pain development. So this is using, I guess, it is from the group in Switzerland, but essentially they're using medical records, and there's always limitations with that, but they're looking at the score after surgery and determining that in the way that they have conducted this study, about 40% of cases had evidence of persistent post-surgical pain. But we need to be aware that there's a negative correlation between weight and Helsinki Chronic Pain Index, so worse outcome for heavier dogs. This didn't necessarily fit with body condition score, but we do know that heavier loading through joints tends to increase the risk of accelerating osteoarthritis development. And whilst TPLO is a nice, if you like, model to use because it's a consistent surgery that's done repeatedly, we do need to be aware that whilst it's an effective surgery, it doesn't stop the development of stifle OA. So that is going to be a confounder when we're looking at persistent post-surgical pain in this particular cohort of patients. We do, however, need to be really positive that people are actually looking at this and being aware that, doing surgery with what is perceived by surgeons to be a good outcome does not mean that the problem is fixed, because this is where we were in human practice prior to 1998, when the surgery was deemed to be successful, but the patients were still painful. And so moving away from TPLOs, there's a recent initiative from Cornell, from Robin Gleed and Louis Campoy, who are the two of the diploma anaesthetists at Cornell, to develop a scale to diagnose and assess post-amputation pain in dogs. And I think this is another important step on our persistent post-surgical pain education pathway. And this was published in VAA a couple of years ago. Unfortunately, VAA is not open access, so it's a case of making sure your institution subscribes to it at the moment. So not to take away from the fact that, in general, amputation in the dog produces positive outcomes. Most dogs are fully functional shortly after surgery, and in the vast majority of cases, it takes away pain. Owners are satisfied with the decision to amputate. So, that's the context in which this has to be taken. If we're amputating for an osteosarcoma, the resultant problems are much less than the problem that we're taking away. But behavioral changes such as aggression, anxiety, compulsive licking or biting, vocalization have been reported and, may reflect the presence of post-amputation pain. And this is post-amputation pain rather than phantom limb pain. Okay, different considerations. So these were what these authors were aware of and decided to investigate this in a little bit more detail. So what they basically did was they took 66 dogs that historically had undergone amputation and 139 dogs that were, if you like, the control population that had TPLO. And they looked at behavioral changes after amputation. And in the interest of time, I won't go through it in detail, but they identified 4 independent predictors of post-amputation pain. And these were restlessness or difficulty in sleeping, episodes of panic or anxiety, sudden vocalization, and compulsive grooming of the residual limb. So if you go back to a couple of things that I said earlier, symptomology is not possible in our patients. They can't report symptoms of neuropathic pain, but much of what we are seeing here is consistent with the presence of neuropathic pain, episodes of panic or anxiety. Spontaneous, is that spontaneous pain? The animals are panicking for no reason. Is it because they're painful and they don't know why? The same with sudden vocalization. And compulsive grooming of the residual limb, we know that that kind of behavior is consistent with changes in dysesthesia or allodynia resultant from the changes to the somatosensory nervous system. So they, with the use of some fairly complex statistics, they showed that taking a score of greater than or equal to 2 of these different indicators showed really good specificity, but not great sensitivity. So specificity of 92% and a sensitivity of 34%. And when they looked at their group to diagnose post-amputation pain, prevalence was 36% in the amputation group and 8% in the TPLO group. So I think it's, to my mind, good evidence that post-amputation pain is characterized by specific post-operative behaviors, and it appears to occur in about 1/3 of canine amputees. Is this persistent post-surgical pain? I would argue that this is pretty good evidence that it is. Does it mean we shouldn't be doing amputations? No, we just have to look at risk and benefit and think about how we're going to manage these patients. But with the understanding that because they can't report and because they're using more than 2 specific predictors, then this looks like it's pretty specific for post-amputation pain. So I think this is something we should be thinking about in a little bit more to do the best for our patients, because this is a procedure that we fundamentally do quite commonly. So we have talked about surgeries that we're doing entirely for patient benefit. Now I'm going to get on my hobby horse and talk about something that we do that I don't think we should do. So this comes from 2 of the most eminent speakers on this out of this last 2 days, Sheila Robertson and Duncan Lascelles, both of whom I've had the absolute pleasure of working with. Sheila when I was a resident, and Duncan I've done liaise with a lot over the past few years as I've started on my own managing pain journey. So this is now a study that is a number of years old. It's from JFMS, long-term pain in cats. How much do we know about this welfare issue? I think we know more, but this was the first iteration of this, first understanding of this. So if we look at the patient group, there's a discussion about DJD and diabetic-related pain, which was very well covered earlier by Sheila and Sarah Caney. And persistent post-surgical pain can occur at any age and is seen in young cats following onchiectomy. Is that a bold statement? I don't think so, because this one has some really good evidence. This is again from JFMS, and this one is open access. The QR code is there. pain and adverse behavior in declawed cats. This is changes in affective state, changes in behavior, changes in how these animals are, changes in what happens to them lifelong because of what we have done to them. So if we just go to down where the arrow is, of the 137 declawed cats, 63% showed radiographic evidence of residual P3 fragments. The odds of back pain, periureopachesia, aggression were increased significantly in declawed cats with retained P3 fragments compared to those in declawed cats without. So they're stating that optimal surgical technique was associated with fewer adverse outcomes, but operated animals remained at an increased odds of biting and undesirable habits of elimination. They also had much more back pain. So we declaw cats, which is done entirely for our benefit. Fortunately, we don't do it in the UK. And we increase the risk of unwanted behaviours and increase the risk of developing back pain. What do you think the etiology of those unwanted behaviours are? Is change in affective state. It's because these animals are fundamentally unhappy, anxious, depressed, multitudinous things. But we know, however good a surgeon you are, does not eliminate the risk of adverse behaviour subsequent to onchiectomy. They call it adverse because they're looking at it from the context of the owner. It's adverse to the owner. But imagine what it's like for the cat. So in cats, we know that invasive surgery, including onchiectomy, thoracotomy, mastectomy, and limb amputation, are likely risks for the development in cats, but the prevalence is unknown. And we know that clinical signs can be observed in onchiectomized cats, and they include lameness, back pain, inappropriate elimination habit, licking and chewing at the digits, aversion of the feet, and altered weight bearing. Well, there's a surprise. I'm sure all of you are aware of this, but I'm not sure that all clients are. And obviously, this is a procedure that is illegal in the UK and has been since before I qualified. It's illegal in New York State and it's illegal in some European countries, but to my horror, it is still legal in much of the US. So as a little bit of a discussion point for your clients, declaw is not declaw at all. Declaw is removal of P3 in all of those digits. And if you look at human data, removal of P3 ranks as a 9 out of 10 on a visual analog scale. That is because our digits are extremely well innervated. Arguably, that may not be quite the case in cats, but they're certainly well innervated, maybe not quite to the extent. So think about taking off every one of your digits from P3 and then wondering why this isn't something that causes suffering, disability, and reduced quality of life. It absolutely does. And to my mind, and I'm pretty sure that most people on this symposium are not the ones that need converting. They're essentially a completely different demographic. Doing this is a major welfare burden to cats. So from my point of view, in that case, as I said, how can we manage it? Well, if it's an option, just don't do it. So we really shouldn't be doing surgical procedures that come with a risk of persistent post-surgical pain if they're not going to benefit the individual directly. And this is the American Association of Feline Practitioners' position statement on declawing, which is pretty direct. We shouldn't be doing it. The same applies to other, what I would consider mutilations, cropping, tail docking, all the rest of it. The somatosensory nervous system is getting damaged to some extent or other. So if we know we have risk factors for persistent post-surgical pain in the patient, anxiety, depression, raised BMI, pre-existing pain, catastrophizing, which seems to be uniquely human, genetic factors. I think we get some owners who catastrophize, never mind the dogs, genetic factors and young age. And these things that we've mentioned before, longer procedures, open procedures, retraction or destruction of nerves, use of drains, Surgery in low volume centres is interesting. If you're having major surgery, go to somebody who does a lot of it because you'll get better outcomes. But we know above all this, poorly controlled perioperative and postoperative pain, so acute postoperative pain, is the single biggest factor that contributes to persistent post-surgical pain in people. So much so that the International Association for the Study of Pain, who are, if you like, the biggest organisation that deals with pain in people, it's 50 years old this year. Every year they have a theme for the year, and the prevention of chronic post-surgical pain was one of theirs. 2020, prevention of pain was a really big thing. And that's really important that we are aware of how important this is in the human world. So what can we do about it, having gone on about how horrible it could be? This is all data from that Pogatsky-Zahn review that I mentioned earlier. The gabapentinoids, recent meta-analysis, so good data from people, showed that perioperative use of gabapentinoids does not reduce the incidence of persistent post-surgical pain, but they may be appropriate in certain patients undergoing procedures that can result in nerve damage. Those things like amputation. Remember that gabapentin or any of the gabapentinoids, so gabapentin, pregabalin, have very little effect on nociplastic pain, on nociplastic pain or on nociceptive pain. They have utility in neuropathic pain. So if we are likely to damage the somatosensory nervous system in a big way, such as amputation, they may have a role, but we do not have strong data to support this. I'm fully aware that the amount of gabapentin that's prescribed has gone up exponentially, but the strategies and the evidence behind prescribing are not good. So therefore we need to use this drug where we have evidence, or we can have an evidence-informed approach that they may be appropriate. Regional anaesthesia has been shown to reduce the risk of persistent post-surgical pain in most types of surgery study so far. You're blocking nociceptive input into the CNS, and we can reduce central sensitization, if not prevent it. But we need to be aware that all of these are not consistent. We do have evidence that not all types of local regional block are going to be effective in every case. So this is something that we just need to be aware of. But even the human data is quite biased and is not that strong. But the overriding direction of travel is that regional analgesia is likely to be beneficial in preventing persistent post-surgical pain. We just need stronger data. Fewer opioids. So for years, when I was young, many years ago, our anesthesias were based on opioids. And we know that preoperative opioid consumption, including chronic use, is a risk factor for persistent post-surgical pain in people. Probably not as relevant to our patients, but it's just something to be aware of, that long-term high-dose opioid use will result in opioid tolerance, changes in the central reward system, and particularly use of ultra short-acting potent opioids, such as remifentanil, can result in opioid-induced hyperalgesia, and chronic opioid use results in facilitated central sensitization and altered descending inhibition, i.e., it does all the bad stuff. So it is an effective analgesic and acutely at high doses, but chronically, it will actually contribute to persistent post-surgical pain. So ideally, what can we take home? Reducing the use of opioids by using multimodal analgesia, regional analgesia, or by using ketamine could potentially reduce the incidence of persistent post-surgical pain. And why ketamine? Well, activation of the NMDA receptor and the microglia are mechanisms that might explain the positive effect of ketamine. So if you give ketamine, you're going to antagonize the NMDA receptors and have an effect on what happens at the level of the microglia. And this is something that is being investigated heavily in people at the moment, the ROCKET trial. 4,000 patients, it's a large multi-center study in Australasia, and the primary outcome is chronic post-surgical pain at 3 months. And this study is just about finished recruiting. It's got over 4,000 patients in it, and we will soon have some data. This is human data. It's data that we'll have to leverage, but I think it's really interesting. Should we use it, ketamine? Well, my argument with the teams here is why not? It's cheap, it's highly effective for managing acute pain. I've literally used it in thousands of cases, and I was talking to the nurses before presenting this, and one of them said, no local block, no ketamine, you're not coming in. Does that mean we're going to solve the problem? It doesn't. But I think what we need to be aware of is persistent post-surgical pain has been identified in veterinary patients and in animal disease models, but we really haven't got the data. It's not been properly investigated. And I don't think as a profession, we've adequately considered it. I'm absolutely thrilled that people who have much bigger brains than me are looking at this, but it is something that I think we all need to be cognizant of. And we absolutely need to be aware that every time we take scalpel to patient, we're risking persistent post-surgical pain. And we always need to think about the risk benefit. Doesn't mean we shouldn't do surgery that's indicated, but it definitely means that we shouldn't do surgery for our own benefit, which things like declaw and tail docking and all the rest of it are. Thank you very much for your time and attention. The weekend has been fabulous for what I've seen of it. I just want to share some of my cats for Sarah and Sheila to have a look at, and to say thank you for your attention. Thank you for listening, and I hope you found some of that a little bit useful.
A little bit useful. Oh my God, Louise, are you joking? And when you turn around and said there's people with bigger brains than you that are spending energy on this, no. We are so honored to have you come and talk for us. That's it's been brilliant. Everybody's been fixed to their screens. Have you got to run to get back to surgery, or can you answer a couple of questions?
No, I'm very lucky. I've got a really good resident who's looking after their bleeding spleen for me.
A bleeding spleen.
Yeah,
Okay.
but then why not?
Why not? Okay, so let's crack on. So Matt, I think Louise has already answered you, so I'm gonna let that one go. We've already answered about nerve blocks. Would nerve blocks help with nerve damage during surgery and PPSP? Pretty happy that you've.
I think so. I mean, the evidence in people is getting there. Would I do one? Absolutely. Risk benefit. It's going to have a huge effect on acute pain, and it's, why not, basically, and do what you're familiar with, do what you're most happy with.
Yeah. This is quite interesting because it is a very pros cons. Thinking about surgery in very young animals and the effects on plasticity throughout life, how does this fit with very young neutering of kittens? Have you had late nights laying in bed thinking about this, knowing more about what the repercussions of what we do can be?
I think you've always got to look at in a risk, in a benefit to the animal versus risk to the animal manner. And I would say that if you're going to be doing it, you need to make sure that the analgesia for it is as effective as it possibly could be. And I think these, and I maybe shouldn't be saying it, but I think in the very young cases, then the use of something like a quad combo where you've got an amount of ketamine in there is probably a good choice, because that's the more and more I see from acute and chronic pain evidence and persistent post-surgical pain, there's not a lot to hold against it, if you like. So,
so Matt, I think she's tackled your question again, because you already talked about using ketamine, regional blocks. I'm going to pose a question because I actually think I've had a case. It was a Scotty post-amputational, and every descriptor that you described. And unfortunately, after about 2 months, we ended up having to euthanize. Have you treated any? And have you got any pearls of wisdom of what could be effective?
I have. I've very small numbers. I'd be interested to see what other people have, done. But our approach very heavily now is prevention as much as we possibly can, rightly or wrongly. That includes a lot of ketamine. It includes gabapentinoids. It includes a block at surgery. It includes a wound catheter. And we do try and follow up. What would I do? Gabapentinoids, ketamine, post, for the cases that I've seen, we've actually brought them into the hospital and gone at them fairly heavily with significant amounts of IV ketamine to see if we can actually have any effect, together with appropriate pregabalin in the last couple that I've done. And we've also had one that wasn't an amputation, but had really persistent pain, and we used the radiology team to do a nerve block, as was described earlier by James and Fernando. We blocked it at C5, just because we could see this was a foraminal stenosis that hadn't done well after other stuff. And actually, as I heard Fernando say, just by breaking the cycle, that did well in the long term. But it was a dog that was screaming before that.
Yeah.
But it's not slightly different scenario, but I think we need to kind of leverage everything we've got in those situations.
No, I think it'd be really interesting to do some kind of collection of data, because this was the same, and it's traumatic for the owners, horrendous.
Yeah.
So yes. Right. Matt's listening intently because he's put 3 questions in. He writes now, I mean oral analgesics in painful cases to give at home, i.e. the week before surgery. Good question, Matt.
Oh, I can't see that. What was the...
So it's right at the bottom. So he talked about using what kind of pharmaceutical procedures, like protocols, and then he's just corrected me because I said I felt that you'd already answered it with the preoperative protocols. He's now suggesting, have you got any advice about oral analgesics like a week prior to an elective surgery in a painful patient?
I mean, I think you treat the pain that you've got and treat the mechanism that you've got, depending on where that pain arises from. So if you've got a patient who is, for example, going to have an amputation but has an osteosarcoma, we will kind of try and manage that pain as effectively as we can with a multimodal approach. And in those guys, that would include something like an anti-NGF, everything that we can.
The whole caboodle.
Yeah. And so I think a lot of it depends on what your source of pain is, or what your mechanism of pain is, and try and manage that as effectively as possible beforehand.
Yeah. Okay. Well, because we only got a couple of minutes. This has stimulated a lot of interest. People were saying, is there any data about tail docking? Equivalent to what we're seeing with declawed cats, and somebody has written about, is there anything about dew claw removal? Is there any data anywhere?
I've not seen anything about dew claw removal. I just don't think we've done it. There is an increasing amount of evidence. If you look at the farm animal data, there's some really horrible stuff about dehorning and tail docking from farm animal stuff, which is coming through. Matt has said, how about the literature that suggests controlling the inflammatory response in the early phases? Yeah, because I think most of persistent post-surgical pain that we're aware of is likely not entirely, but has a big neuropathic component. So I think that seems to be where the human literature focuses, rather than on managing inflammation, which I think is fair enough. But I certainly don't think, just looking at these, we don't communicate the risk of persistent post-surgical pain at all. In fact, I don't think most vets are aware of it. It is interesting, and many of you will know Polly Taylor, who had a long conversation with her own surgeon and anaesthetist prior to her surgery about managing persistent post-surgical pain. And I know that I've got a good friend who works in one of the London centres who has an interest in persistent post-surgical pain, and they heavily counsel patients, and they look at some of those psychosocial factors and then try and look at the people who are going to be high risk, which we obviously can't do.
No. It's gonna be fascinating how this pans out. High five you. High blinking five you. I've been waiting for this all weekend. So I'm so excited to have been able to listen and host the questions.
I hope I haven't disappointed. Sorry.
No, you have not. Thank you, Louise. Seriously, lovely lady. Please do, tune into whenever she's lecturing again. We're going to all have to go because we've got two very, very cool people coming up, like super cool. We've got Kristen Kirby-Shaw and Leilani Alvarez, who are going to be talking about exercise and its involvement in chronic pain, which follows on really nicely from Amber Batson, and it follows on from the amazing Tasha Stanton that we had yesterday. So please, guys, say thank you to Louise. Unfortunately, she's got to go back to work. But you haven't finished work yet either, guys, because you're getting to the next session. We've got 2 more to go, and then we've completed the 3-day event. Thank you, Louise. Take care.
See you later. Thank you. Thanks, everybody. Bye.
It's not playing a live stream. It's not playing a live stream.
I think that's Kristen. I've just
feedback issue. You want to do the intros, Jade, whilst we're getting that sorted?
Ooh, that was super weird. I'm glad you sorted that out.
No, that's okay. Kirsten, do you think, have we sorted that?
Good on my end.
Perfect. It sounds a lot better now. So no, that's brilliant. So yeah, welcome everyone. Sorry about that slight technical issue, but never mind. So yeah, we've got another fantastic talk now from Kristen and Leilani. I just would like to thank our sponsor for this talk, which is NAVP, the National Association of Veterinary Physiotherapists. Kristen and Leilani are going to be talking to us about exercise and pain management, which I think is going to be really interesting and really useful for all of the different types of professionals that we've got watching us today. I mean, how many times are we asked in our day-to-day jobs about sort of exercise recommendations from our caregivers? So this is hopefully going to give us sort of more advice and equip us to better answer those questions. So 2 incredible international speakers. Kristen is a small animal surgeon and rehabilitation specialist with a very interesting career, but she also has founded the website caninearthritis.org, which is like the US version of CAM, which obviously we love. Leilani is a board certified diplomat in veterinary sports medicine and rehabilitation, and is the director of integrative and rehabilitative medicine at the Schwarzman Animal Medical Center in New York. Thank you so much, and I'll hand over to both of you.
All right. Thank you so much, Jade. And thank you to Hannah and everyone at CARE for the opportunity to be here and be part of this amazing symposium. The lineup is incredible. And for those of you guys that have been watching all weekend and all day, thank you so much for sticking around. So what Leilani and I are going to cover today is, as mentioned, we're going to talk about specifically the role of exercise when it comes to chronic pain management in the context of osteoarthritis. And I think this comes as an important topic because historically or traditionally people think that dogs with arthritis with OA shouldn't exercise, when in fact that's probably the worst recommendation that we could give. So what we're going to cover here in the next hour or so is what I'm going to talk about is sort of the background and the science of, well, does exercise play a role in OA management? I'm going to say right off the bat, yes, it absolutely does. I'm going to review some principles that we can try and follow as we design exercise programs. And really, right now at this point in our evolution of exercise in the veterinary world, we're having to turn a lot towards the human side and the physical therapy, physiotherapy, to grab some of their principles and take them to what we can do for our animals. And then I'm going to turn it over to Leilani, and she's going to take the practical side and talk about some of the exercises that she uses with her patients. So first of all, just asking this question, can exercise reduce OA pain? The short answer is yes, but we've got to have a little bit more thought around that. Which exercises do we choose? How do we dose them? How do we progress them? If we turn towards the human literature, there's actually a plethora. There are so many articles out there looking at various types of exercise, and then these articles are put together into systematic reviews and meta-analyses. And so on the human side, there's sort of no doubt that exercise plays a crucial role in managing osteoarthritis. One article that we're just going to kind of work through here is specifically looking at the role of exercise, diet, biomechanics, and physical therapy interventions, but I want to tease out the exercise component. And this article states that there's robust evidence based on randomized clinical trials that support exercise along with education and diet as core treatments for OA. So those are the foundations. When we're talking about an OA management plan, we have to consider exercise. These exercises should be structured and supervised. Now, that's important. It's not just go out and go for a run or do some sort of exercise. We do need to give some guidance and some structure around which exercises to choose. And this is going to be a kind of a theme that we pull throughout this presentation, is that while the mode of exercise may vary, it is important to individualize it for the individual patient based on what their disease state is, what their comorbidities are. And then that dose, meaning how many repetitions or how frequently they do the exercise, should be based on an initial assessment, then progressed as appropriate, again, individual for that individual patient. If we look towards the veterinary literature, there were a few different guidelines that were published in the last few years that give us some indication of what we should be choosing from the veterinary literature as our foundations for managing OA pain in dogs and cats. And the WSAVA, the World Small Animal Veterinary Association guidelines, did specifically call out that exercise is one of the foundations for managing OA pain in dogs. So the benefits of exercise are many. Exercise can be anti-inflammatory. It can reduce generalized inflammation. And we know that inflammation certainly plays a role in the disease of osteoarthritis, both on a local level and also systemically, meaning and especially adipose tissue and other areas of systemic inflammation. Exercise can actually release anti-inflammatory cytokines, which is incredible to me. So we don't actually need necessarily a pill or an injection to reduce inflammation. We can just exercise. Not surprisingly, I think this is where our mind initially goes, is exercise is able to improve or maintain activities of daily living, or ADLs. Now, this, of course, is the thought of we can strengthen muscles, we can improve range of motion in joints, and therefore allow an animal to be able to get up from a laying down position, to go up and down stairs, potentially to jump in and out of a car. So one of our absolute goals with an OA patient is to maintain their functional independence and those activities of daily living. Improving cognition, and this kind of goes hand in hand with the next one, which is improving mental health. There's undoubted evidence on the human side that exercise can reduce signs of dementia, or at least the progression towards dementia, and improves general cognition, and certainly plays a role in mental health. Now, we really don't have great evidence at this point to tie exercise to cognition or mental health in our veterinary patients, but we do know that when we think about the pain of osteoarthritis, there is an emotional component to that pain. And if we can allow a dog to enjoy the activities that are important to them, that's probably going to help with their emotional state. So we can kind of tease that over to say it's probably helping with their mental health and their cognition as they age. And then very, very importantly, exercise can help reduce the pain of OA. And that's not just through reducing inflammation. It has multiple different mechanisms that I'm not going to go into all of the nerdy details here, but there's multiple mechanisms in the pain pathways where exercise can reduce pain. And on the human side, it's been shown to be at least as effective as NSAIDs in reducing osteoarthritis pain. However, there's a caveat to this. When we think about what is important when designing an exercise plan, we can't, as I mentioned, we can't just say all exercise is good. What do we have to think about? And so these principles that come from the human guidelines, there's 11 principles, and we're going to go through each one of these and try and take what we can from the human literature and guide us in our decision making on the veterinary side. And so first of all, it's using an evidence-based approach, or at least an evidence-guided, evidence-informed approach to making our decisions. Now, everybody has seen some sort of picture that looks like this, the levels of evidence, our evidence-based pyramid. And today in veterinary medicine, we are at the bottom of the pyramid when we are looking for guidance from the evidence to tell us what types of exercises to choose. So we are looking at translational studies. A lot of what we're talking about here is what do they do on the human side? Couple case reports and case series, and then expert opinions. That's Leilani telling us what she does for her patients. And so hopefully one of these days we will have more robust evidence to help guide us as we decide what exercises to do for our patients. So until then, here's one of the few studies that we do have to help guide us. And this was a study done out of North Carolina State University, where it was dogs with hip dysplasia, 60 Labradors, and they followed these dogs prospectively. It was not a randomized trial, but they followed them prospectively. And ultimately, what they wanted to know is, did the duration of exercise determine the dog's lameness? Meaning, if the dogs exercised for less than 20 minutes a day, 20 to 60 minutes a day, or greater than 60 minutes a day, how did that relate to the dog's lameness? And what they found, interestingly, was that exercise was associated with a decrease in the severity of lameness, specifically and mostly for the dogs exercising more than 60 minutes a day. They also did not find a difference between what the type of exercise was. And that was honestly a surprise to me. I thought that there would be a difference between low impact and high impact exercises. So for me, what I take away from this article is that 60 minutes a day certainly is a great goal to work towards, but that's not where we're going to start most of our exercise programs. That's something that we can work towards. And I still generally prefer low impact exercises versus high impact ball play that can be really tough on joints. So I think Leilani is going to talk to us a little bit more about how we would take this information and apply it to our patients. But while there is evidence to suggest in veterinary medicine that exercise helps reduce lameness, on the other hand, there is evidence to show that it can increase lameness. And this specific study was looking at whether there was an impact on the measurement of ground reaction forces, or using a force plate analysis, whether exercise reduced those forces through the joint. So let me back up. Force plate analysis is what is used to measure how much weight a dog places through their limb. They walk across the force plate. That's considered gold standard for measuring things like recovery from surgery or weight bearing through a limb. So this study showed that dogs that did not have arthritis and did not really have a change in how much weight they put through their limb after they were exercised. And exercise was trotting for 1.2 kilometers. Whereas dogs that did have osteoarthritis did show a decrease in their weight bearing through through that force plate after they were exercised. So what this really does tell us is that exercise can cut both ways. It is very beneficial. But if a dog has osteoarthritis and they are painful, they may not want to bear as much weight through their limbs. They may hurt. So we have this vicious cycle that can lead us to, well, I hurt, so I don't want to exercise. And then I'm not going to exercise, so I hurt even more. And we lose those benefits that can come with exercise. So when we're starting an exercise program and plan, we do always need to try and intervene with some sort of analgesia, meaning this dog has osteoarthritis. We need to control their pain with whatever tool in your toolbox you want to use, whether it's NSAIDs or injectables or anything else. we've got to get on top of that pain management first so that we can start a good exercise program. Now, the next principle is we've got to consider the exercise in the context of living with OA pain. And really what that means is the practical aspect of this plan. It needs to be sustainable in the long run. So we need to work with our pet owners on developing something that's going to fit into their lifestyle. Just telling every dog owner to go take their dog for a 60-minute walk every day is probably not going to be practical for most people. So we need to work with them to develop something that's going to work long term. Another important point is to recognize that sometimes there's an acute exacerbation in that pain during exercise, meaning there can be a flare-up of pain or they feel a little bit more sore during exercise. And from the human side, they say that that's okay as long as the pain returns to a more normal level, returns to baseline or better within 24 hours. Of course, for us, it's a little bit harder to know what that means. And the biggest challenge I think we face in managing OA in dogs is assessing their level of pain. So for me, if we think there's any degree of soreness or setbacks, I'm not going to hesitate to use a little bit more on the analgesia side and make sure that that dog gets back to their baseline within a day, 2 at max, before we progress anything further. Next 2 principles, we have to have a baseline assessment, and that is going to guide us on where do we start, and then how do we follow that up. We need to make sure we understand any comorbidities, and this is really important when we're talking about our older and our geriatric patients. Do they have laryngeal paralysis and polyneuropathy? Do they have any other medical conditions that may interfere with our ability to put together an exercise plan? And then we need to have goals. This goal setting really should be based on our SMART goals, meaning specific, measurable, attainable, relevant, and time-bound. And the way that I like to approach this when I'm in clinics is I use a client-specific outcome measure, and that's the form shown on the left-hand side of your screen. So I work with clients and ask them to pick 3 activities that their dog has a hard time doing. It could be, my dog has trouble climbing the stairs at the end of the day. My dog has difficulty jumping in the back of the SUV. My dog lags behind after we go for about 5 minutes of walking. So we pick 3 things and we have them as specific as possible. Then we put together a plan, and our goals are to improve these at least 3 baseline problems that we're starting with in some predetermined time period, whether it's days, weeks, or months. So that's going to be our ideal way that we're kind of putting these goals into action. Number 5 is considering the type of exercise. So we can look at whether it's aerobic exercise or strength training, neuromuscular exercise, balance, flexibility. And we're going to pick and choose exercises from these different categories based on what that individual dog's problem list is. And we are going to address their particular functional limitations. So we can take, all of these different types of exercise, put them together and say, what does this individual dog need? On the veterinary rehab side, we've got things like cavalettis that can say, all right, well, we're going to improve this dog's range of motion, or whether it's hydrotherapy that can do really well for cardiovascular and endurance training. So what is most important for this individual dog? So when I try and think about these exercises, I really try and think like, what are the functional limitations, and sometimes even use those functional limitations as therapeutic exercises. And if they, for example, dog can't stand up, well, we're going to do variations of down to stand to work on their ability to stand up. And it may not be getting them originally to go from a down to a stand. We might break that into smaller exercises, working on range of motion on the joints, working on core strength, working on strengthening of the pelvic limbs, and all the little pieces that go together there. So here's the video. I think the videos might be acting up a little bit on your end, and I apologize for that. But really what this is demonstrating is a dog who she has stifle osteoarthritis. She's had some lumbosacral pain as well. She's got shoulder muscle pain. And while her bed is not in the most appropriate location here, because she's trying to stand up on that slick floor, she really, really, really struggles to stand up. So if I see this and I know that, well, before anything else, we really need Zuli to be able to get out of bed, we would work on exercises to try and break that down. And this would be an exercise, probably not for Zuli, but for other dogs, just doing the down to stand. For a dog that still is able to get up on their own, this is one that I really, really like to incorporate. This was my own dog. She's no longer with us, but I incorporated her down to stands because she, being a French bulldog, had some neurologic issues, also had some hip arthritis. And so she would do about 8 to 10 repetitions 3 times a day just before she was fed. So I would use the kibbles, have her do her down to stands. And one of the benefits of doing it this way is that I never forgot to do her exercises. It was that habit that was stacked along with feeding her every day. So that's one tip that I definitely like to suggest, is trying to stack on exercises with something that you're already going to do for that patient. So now, dose recommendations. Leilani is going to talk more about what we do with animals, but from the human standpoint, there is some pretty good research out there, at least some guidelines that suggest at least 12 supervised sessions a week, at least 12 supervised sessions in total when starting a plan, with 2 to 3 sessions a week, each session being about 30 to 60 minutes, plus 1 to 2 days a week of home exercises. And I think for me, running a rehab practice, when I was running a rehab practice, I think this was something that we strived for, was to try and get dogs in to about twice a week. But we certainly always gave home exercise plans. From strength training, this is where we definitely don't have the research on the veterinary side in terms of how many sets or reps, or what the percent of one repetition max. That's what that 60 to 80% there is. That's something that we need to work towards in the future, is understanding the guidelines for strength training in veterinary medicine. And then neuromuscular, on the human side, recommendations are supervised exercises twice a week for at least 6 weeks. And I think that's probably good guidance for us as well. All right, moving along with our principles. Number 7 is to modify and progress the exercise. So we have to progress the exercise. If we keep doing the same thing day after day after day, week after week, month after month, well, we're never going to gain anything. We're never going to gain strength, flexibility, endurance. So we do need to progress. And of course, coming back to that theme I told you was going to pull through, is that individualized plan, and certainly gradual. And so we can't progress that plan unless we're reassessing the patient. And that is absolutely one of the benefits that we have on the rehab physiotherapy side, is that we do get to see our patients back on a pretty regular basis to give them that check-in to progress them. And then here's one important point. Sometimes we have an animal that has a particularly painful area, a particularly painful joint. And there can be, understandably, reluctance to have them move that joint or exercise that limb. Well, exercising the rest of the body can still give us some of those benefits. We can still have some of those generalized anti-inflammatory effects. We can still have some of that generalized, we didn't cover, but the release of endogenous opioids. So even if you can't truly exercise the joint or the limb of interest, doing some sort of whole body or exercise for the rest of the body will be beneficial. All right, I can't overemphasize this. We have to give guidance to our dog owners, to our pet owners, on how to do the exercises we're recommending and how to do them properly. And also, what are some red flags to look for? When should they not push their dog too hard? When should they stop? We give them guidance of 8 to 10 repetitions, but when should they really call it quits with about 8 repetitions? So really providing easy to follow instructions, not overdoing it. So in human PT, physiotherapy, physical therapy, it has been found that, first of all, humans are very poor in terms of their compliance to a home exercise plan. About 30% of the time they'll adhere to it. And if you give them any more than 3 exercises, those humans will not do any of the exercises that they are prescribed. So we don't have that data on the veterinary side to say what is the adherence of our patients and caregivers performing these exercises, but I still generally stand by that no more than 3 exercises at a time, trying not to overwhelm, trying to ensure that compliance is there, and the pet owners are doing the exercises properly. And so if we can have them work these exercises into their daily routine, like I did with Beans, my friend, she giving her several kibbles each time that she did her down to stand before we fed her 3 times a day. We got those reps in every day. So finding something that it can be worked into the regular routine is a big advantage there. And then providing education about OA and the role of exercise. And not, I want to say, we're going to talk about the role of exercise, but providing education about osteoarthritis. Our pet owners, our dog owners, they hear that word, they hear the phrase osteoarthritis, and they think it's a death sentence, and it doesn't have to be. This is something that Hannah and I both very, very much agree on, is that part of her founding CAM and mine with CARE is really trying to give support to dog owners so they understand what they're up against and all the things that we can do to help dogs live a long, healthy life. So our pet owners have to understand that OA is a disease process, and the pain of OA is its own disease. It's lifelong, it's progressive, but it is manageable, especially if we start early, especially if we keep that dog lean. I mean, we're not talking too much about weight control and weight management here, but keeping that dog lean from a young age is the most important thing that we can do. And then keeping them moving. The influence of activity. So we're talking about the benefits of activity, the good exercises to do, but I generally talk about what exercises to avoid and what not to do. So I try and discourage that high impact jumping down ball play, unless that dog lives to play ball. That pet owner thinks my dog would not want to live if he didn't get to chase the ball. Well, then we've got to start realistic expectations. We've got to say, well, if your dog has elbow arthritis and they're chasing and pounding onto that elbow repeatedly, their lameness is going to get worse. Their OA is going to progress worse than it would otherwise. And so we might have to be more aggressive in what we're doing to manage that pain. We need to talk about effective and ineffective therapies. There's a really big toolbox of things that we can be using. Not all of those tools come with the same degree of efficacy. So we do need to prioritize those things. And then, of course, what to look for. What are the red flags whether they're doing exercise or whether it's just osteoarthritis in general? When is more analgesia needed? So these are important conversations that we have with our pet owners. And we can give them some really great resources. Of course, CAM is just the most outstanding website. Hannah is incredible and the whole entire CAM team for everything you guys have done. So we can send them to these valuable resources. CARE, that's caninearthritis.org. There are some resources on here of specific therapeutic exercises. These are the exercises I like to share with my patients, my clients. So that's my bit, that's my background, and I'm going to turn it over now to my good friend, Dr. Leilani.
Thank you, Kristen. As always, your lectures are on point. I couldn't agree more with everything that you said. Of course, we talked about these slides together, but just listening to you, I just want to point out a couple of really important points that Kristen brought up during her lecture that are very relevant regarding our go-to exercises, which is you have to have an individualized plan because it's not going to be the same for every dog with OA. And those SMART goals, really customizing it to the patient needs and where they are at that moment. Because you may have a dog with OA, let's say a really common one that we see, which is stifle OA because they tore their cruciate, and maybe they're having difficulty sitting, but they're not having as much difficulty walking. So maybe then the exercises that are really relevant to that patient are going to be related to sitting, as opposed to another dog that might have hip OA, maybe it's more related to the walking. So again, really know your patient and make an individualized plan and start where they are at. Maybe the dog can't even get up on their own right now. Does that mean that it's not a realistic goal to help them to get up better? No, I don't think so. But we do need to start where they are at. So how do I then begin with an individualized plan? Well, I'm going to start exactly where the patient is, and we're just going to add a little bit. Maybe it's increasing frequency by just one more thing. So let's say that the difficulty is with the walking. Say, for example, I used to take my dog out 3 times a day for a walk, but now, he's really only tolerating one walk. So then I'll say, okay, how about we're going to take your dog out for one more walk, and it's just going to be getting up and getting out the door. We're just going to start there. So we're just going to build a tiny little bit to where your dog is right now. And then we're also going to increase the duration slowly. So for example, going back to the example of the walk, we increased the walk by just getting up and getting out the door. And maybe we're going to add a minute more to the walk that we're already doing. So doing both of those, a little bit increased frequency, a little bit increased duration, always low impact. Kristen already mentioned this, but it's really relevant for OA because we know that those concussive forces in the joints are going to flare up the joint. So really keeping those to low impact activities. That doesn't mean actually that the dog can't go for a walk or even honestly trotting. I'm not that opposed to trotting, but jumping, that's a big one that we're not going to want to do. Stairs, those are more difficult. It's like maybe not completely out because stairs might be a really important functional exercise, but maybe we're going to have a harness on the dog so that when they take that step down, maybe we're assisting a little bit to reduce that impact. We're also going to begin with isometric exercises, and that's really important. I'm sure this has been mentioned during the symposium today, but just so we're all on the same page, isometric means that the length of the muscle is not changing. So it's kind of like a yoga exercise where maybe we're lifting one leg, and then the remaining leg is going to have more contraction of those muscles, but the length of the muscle is not changing, meaning it's not a dynamic movement in the joint. The joint is remaining stable, but the muscle is contracting. That's what we mean by isometric. That's always a really good place to start, particularly for OA, because maybe it hurts to move that joint. So we're going to strengthen those muscles by allowing them to contract more, both with duration and frequency, but we're actually not doing anything with the joint. And then really, really important, it is all about those daily activities and functional exercises. So really think about your individual patient and those client outcome measures that Kristen talked about. Like, what is it specifically? What activities is your dog having difficulty with right now? And including functional exercises that are going to help improve those activities. And then always, no matter what exercises you're prescribing, it must be on a traction surface because we know that dogs with OA have decreased proprioception. They are definitely at higher risk for slipping, falling. They just don't have the perception of space, of their limbs in space, like a dog without OA does. So make sure that we're not increasing that risk by forcing them to do an exercise on a surface that is not as stable as possible. So always begin on a neutral surface and always use traction. The other thing that I really love in developing an exercise plan, and this goes for everybody, but it certainly applies for your OA patient, is just making it a balanced exercise program. Because it's really easy for us to think about, okay, I want my dog to walk longer, or I want my dog to be stronger so that they can get up easier. And that's great. But we know from human exercise plans, even when it's very sport specific for an athlete, like, maybe we have a swimmer and we want them to complete their race faster. And so you think, okay, then the way we're going to train for that is to swim and push speed as much as we can. But actually, if you want to improve speed, you need to include some strength. And actually, your proprioception needs to be really good also. And what about your flexibility? Well, if you have more flexibility, your stroke is going to go a little bit further. So make sure that when you're creating an exercise plan for your OA patient, that you hit these 5 basics. It might just be a tiny little bit, but at least think about them. We want strength, we want endurance, we want balance and proprioception, flexibility and range of motion, and then specific to the task at hand. So those are my 5 exercise basics that I'm going to try to include in every plan. And then let's just talk about now the specific exercises. I picked some that I thought, okay, even with contraindications, this is probably going to be okay for most patients. So this is a patient who was actually suffering from pretty advanced hip OA. He's definitely having trouble getting up. And so we began with an elevated stand. This is an isometric exercise. You can see I have a yoga mat there. Again, because we wanted traction surface, I'm having the dog step up to a little bit of an elevation, which is going to bring more weight through the rear limbs. And then I'm repositioning, so it's a square stand, and then asking the patient to hold that position. So you see I'm correcting it, and then the patient's holding that position. You could even take the treat in front of the nose and have them extend a little bit more. That helps ensure a neutral spine. I'm going to bring them off of that elevated surface, and I'm going to bring them right back on. And it's important that you see how little the break is between doing that elevated stand and then I'm bringing the patient off and immediately back on. You don't want your time between reps to be too long, because you really do want to adapt that muscle for that improved strength, which means we need to build on that muscle at the time when it maybe is starting to fatigue a little bit, and we're just going to ask a little bit more of it. And then this then is the trigger for adaptation to improve strength. So this exercise is really great for building hind limb strength. You might think about this for dogs that have hip OA, stifle OA, tarsal OA. Again, even if those joints are hurting when they're in the elevated stand, we're not asking those joints to change in position. And the elevation can begin really, really small, like in this example with just one little block. I don't ever go higher than elbow height in the dog. And what height you choose is really dependent on what the dog can do right now. Again, begin where they are at and then build from there. So you can certainly increase height to bring more weight through the rear limbs. You can increase frequency. You can increase duration for this exercise. And then let's talk about another isometric exercise, which would be a 3-leg stand. You'll see this is an obese patient who, in addition to improving his functional mobility, we were definitely doing weight loss as well. But you'll see in this exercise that I am lifting a pelvic limb, and then he's holding that 3-leg stand. So this is a strength exercise and a core exercise because the dog is having to balance on 3 legs. So it improves proprioception to some degree because he's having to balance on 3 legs. It's definitely increasing strength on the pelvic limb on the other side and the front legs. You can also have them give you a front leg, and this will also build strength in the pelvic limbs. Basically, any leg that is remaining standing is going to be a strengthening exercise for those. Whenever possible, I do prefer for the dog to voluntarily do the exercise. So when the dog is giving me his front paw, he's voluntarily doing that, which means then that he has to gain his own balance and engage his own muscles in a way that feels right to his body, as opposed to when I did the hind leg elevated stand where I lifted the leg for the dog. If possible, you can train a dog to target and lift their own back leg. It's much, much easier, of course, in a front leg to ask them to give paw. It's like shake. But whenever possible, again, definitely have the dog do the exercise voluntarily. And then again, in this example, how would I progress it? Well, initially, I'm just going to have the dog give me that leg, and we're not even really holding very long. I'm going to put it right back down, but then we're going to go straight back into a second repetition. And same with the rear leg. And then how could you even further build that? Well, we can hold the position for a little bit longer, and we could also increase the frequency. Regarding endurance, there's a few ways that you can improve endurance. So think about endurance as your heart needs to beat faster to keep up with the exercise. So what kinds of exercises require more endurance? Well, the ones that I think about are most relevant for our canine patients would be walking, but also swimming. If you have the pleasure of a rehab facility where they have an underwater treadmill, what's really nice about doing walking in an underwater treadmill is not only are you asking the cardiovascular system to pump a little bit more blood to get to those muscles, but you're also walking against the resistance of the water, which could be really, really beneficial, not just for strength training, but actually also proprioception, because the body has all that water surrounding the limbs and you're actually increasing proprioception. So in this example, this is our same patient that you saw doing the elevated stand, the one with the hip dysplasia. He's walking in the underwater treadmill without assistance. He's licking peanut butter. I always laugh because I'm like, man, if I could go to the gym and like be licking like ice cream while I'm on the treadmill, then that would just be awesome. But you always want to keep it positive, and you want it voluntarily. So this allows your patient to stay up close so that they're not riding the treadmill back. And it's also a positive reinforcement, which we always want for our patients. And then you have the side view where you can see he's achieving a really normal gait. And part of the things that you can do is play with the speed of the treadmill to emphasize what you want to improve in the patient. So for example, sometimes when you want to increase stride length in a dog that has hip OA, you might actually have them go a little bit slower so that limb stays a little bit longer in the stance phase before they go into swing phase. But just play with it because you always want it to be a normal gait, but you can play with it to potentially increase the stride. Also, you can lower the water level if you want to have a more range of motion in the joint. So rule of thumb is you want to be just above the joint that you're trying to emphasize range of motion. So for the hip, we're going to be right at hip height or just above. If you're trying to improve range of motion of the knee, you're going to be just above knee height. If you're trying to improve range of motion of the tarsus, then you're going to be just above tarsal height. Okay, moving on to the next exercise that would be endurance, would be walking. Than walking on grass or in a park. So I do ask my owners, hey, if possible, can you take an Uber or can you use a stroller and get your dog out to the park and then do your walk there? In addition to it being lower impact, it's also a different texture. So you can think about, again, improving that proprioception, because if the dog is walking on grass, they're getting more nociception into those paws and maybe allows them to have a little bit more awareness of where their foot is in space. You can also do all sorts of tricks indoors. The example I'm showing here is with an air mattress, which most people, even in an apartment setting, you might have an air mattress already, or you could use a cushion that's already on your sofa, for example, just to make it a little bit more uneven. It just challenges the dog a little bit more. And then going back to the study that Kristen mentioned that I love, that green study that talked about dogs with hip dysplasia and exercising more than 60 minutes a day actually reduced their lameness. So that is actually what I am aiming for in my patient. Again, always keeping in mind, where is my patient at? I'm not going to necessarily start there, definitely. If right now they can only walk for 5 minutes, and that's where I'm going to begin. But one way to think about how we can achieve that 60-minute a day exercise is breaking it up. We know that dogs with OA are going to tolerate a shorter duration but higher frequency exercise much better than a longer duration, shorter frequency. So as an example, if a dog is right now going out for a once daily, let's say 45-minute walk, and we're trying to aim for 60 minutes a day of walking, well, maybe we add a second walk and we break that down into 2 20-minute walks, which is actually less than the 45 minutes they were doing, but maybe the quality of the walk is going to be better. For dogs that are not very exercise tolerant, we might begin with 6 outings a day that are just 10 minutes. But guess what? After those 6 outings, you get to 60 minutes, whereas a dog otherwise would never tolerate 60 minutes of exercise. Or maybe we go out 4 times a day for 15 minutes or 3 walks for 20 minutes. So definitely get creative about how you can increase frequency with shorter duration in order to get to that 60 minutes of exercise a day. I actually like to think about that 60 minutes a day from that green study as my goal as a human to get 10,000 steps a day. And I say that to my owners is, if you're using a smartwatch to hit your 10,000 steps a day, for your dog, it's 60 minutes a day. Like try to get in that 60 minutes of walking per day, but you can certainly break that up during the day. You don't need to do it all at once. Okay, another exercise, we've been talking a lot about balance. Here's an exercise that's also isometric, really, really simple. Again, we're on a traction surface, we're on a yoga mat, same patient with the hip OA. I'm just shifting his weight by putting a little bit of pressure over the lumbar area. You can do it right on the side of the hips. And I'm swinging the dog, and the example I used where I pushed really hard and he lost his footing, that's what you don't want to do. So just weight shift enough so you can see that they're moving, they're catching their own balance, but don't push so hard that their foot actually has to raise from the ground. And again, you can definitely progress this because maybe you do this exercise on an air mattress, maybe you do it on a cushion, maybe you do it on mulch outside, on pebbles, rocks, different textures. That's going to challenge them even further in that proprioception and balance. But balance and proprioception, really, really important component to your exercise program. To challenge proprioception even more than just shifting their weight, you can actually have them walk over obstacles. So it's not available to everybody, but you could use Cavalettis. If you have a rehab facility, they will definitely have Cavalettis available to them. So you can see here a patient that had pretty advanced elbow OA, and we're having him step over these obstacles in order to improve flexion of the joint. But it's also really important for awareness of where limbs are in space. If you don't have Cavalettis, maybe you have a hose outside, and you can see we did that for this patient who was having difficulties. You just set it up in an S figure and have them walk across these obstacles, which really improves awareness of where the limbs are in space. If you have space and you have a ladder, you can lay a ladder down outside in the yard and have the dog step over the steps while that ladder is sitting on the ground. I've had people in New York City just lay out books and different things where the dog has to walk around them. So even if they're not stepping over them, they still need to recognize there's a barrier in front of me and I need to avoid that barrier. So those are just creative ways where you can include that proprioception aspect of your exercise program. Another one that's particularly helpful for dogs that are experiencing postural deficits is what I call a foot to floor. It's almost like you're striking a match with their paw on the surface of the ground. And then I switch to the other side. I call this a 3-for-1 exercise because it's an isometric exercise. You're lifting one pelvic limb, which means that you're getting strengthening to the remaining 3 legs. It's a range of motion exercise because you're moving that leg and all of those joints through a range of motion. And it's a proprioception exercise because as you're rubbing that paw on the surface, you're improving that nociception and that awareness of sensation. And you'll see that when I do it for this dog, I'm doing a few repetitions on one leg, I switch to the other leg, and then I'm doing this little bit of a tail stimulation, which is really helpful for bringing more nerve supply and awareness to the pelvic limbs. And I'm telling you, it's magic. If you do this for a dog that's having very mild postural deficits, you'll do this little routine, foot to floor, about 5 reps on one side, 5 on the other, little tail stimulation, and they walk, and it's a miracle. They look like they don't have any postural deficits at all. So this is a really easy trick. Again, generally okay to do with any patient. Good. Okay. Last bit, actually not last bit, fourth one in that basics of the exercise, things that you want to include is flexibility and range of motion. This is a really lovely video that Kristen did with her dog. Where it's just going to show you doing a bow, like a play bow exercise, which is really great for improving flexibility. So that means a muscle being able to stretch out longer for the shoulder muscles, especially the triceps, which is a muscle that tends to get overutilized in dogs that are experiencing any kind of a hind limb weakness. So hip OA, stifle OA, anything in the pelvic limb, they're gonna overutilize their triceps and their forelimbs. So doing a play bow exercise, a way to regain flexibility of those muscles in the shoulders. And let's just play it again so that you can see how Kristen is training this. You're going to put a treat down in front of them, between their front legs. Keep your hand under their belly in the pelvic limb so they don't go down all the way, and continue to reinforce that until they on their own achieve that play bow exercise. One of my favorite ones for improving flexibility in the forelimbs. And you're also actually getting nice extension of the spine, which is always a good idea. So that's flexibility, meaning that the muscle is stretching out a little bit more. Range of motion has to do more with the joints. And so let's say the dog has elbow OA and they don't have great range of motion in their elbow. You can teach them to give paw And you'll see here when I have the dog give paw, I actually push the leg towards the chest to get a little bit more flexion in there. So a lot of times we teach this give paw and then stop from there, but a little trick to get improved range of motion, particularly because most dogs with elbow OA are going to lose flexion a lot more so than extension. So just when they give you that paw, push the leg in towards the chest to get just even more added flexion of that elbow. Again, do repetitions. I typically do at least 3, and then you can also hold a little bit longer just to emphasize that range of motion. And I know we're running short on time. Functional exercises. I know Kristen mentioned, difficulty getting up. It's one of the most common ones for OA. So this is the same patient with hip OA. I had him do sit to stand exercises because this is precisely what he was having difficulty with. I'm using a yoga mat, again, traction surface. He's sitting, and then immediately I'm asking him to rise and then go back again. The exercise, again, is that repetition immediately after they do the exercise. A modification of this, if a dog can't quite achieve this on their own, is you can either have him sit onto your lap or sit onto some yoga blocks so that it's a modified sit. So maybe they don't sit all the way down, but they go into a squatting posture, and can be really beneficial for dogs that are having difficulty posturing to eliminate or difficulty rising. And then I just wanted to show you this patient that we've been seeing all along in these exercises. This is what his x-rays look like. So you can see he had really, really advanced hip dysplasia. What I would call, I don't know, some people call it end stage. He probably was subluxating his hip. And you can see the next slide here is how he presented initially. You can see that he was really stiff. His stride length was short. You'll also see, it's not wanting to play.
Play. Yeah, it's saying it doesn't want to play. Sorry.
Oh man, bummer. Okay. Oh, and so does the next one not show either? That one's going. All right. Well, trust me that on initial, his stride length was much shorter. He was really, really stiff, and he was also fatter. So you see, after 8 weeks of doing the exercises that I showed as examples here, he was walking very fluidly, moving on his own too, like he was asking mom to go on more walks, and he'd also lost weight. So there you can see the benefits of doing these exercises. And just as a summary, key points from the things that Kristen reviewed with you and also the exercises is that the reason why we care about osteoarthritis is because it causes pain. And remember that exercise is actually a means for improving pain management in OA. I like to say that the biggest enemy of arthritis is immobility. If you immobilize a dog with OA, their symptoms will be a lot worse. So individualize the program, start where they're at, but mobilize them. It really is going to improve joint health. The benefits of exercise are many. It's going to reduce pain. It's going to improve strength, activities of daily living, and definitely mental health. Customize those exercises for the individual program. Choose exercises based on their functional limitations. Don't ask them to do something that they cannot do, and make those smart goals. And also really, really important is that you reassess regularly, both for progression, so that they can continue to improve, or maybe you need to back off if they're not doing as well or potentially getting worse after an exercise. And with that, I would love to open it up for questions for either myself or Kristen. Thanks for hanging in there.
Oh, thank you so much to both of you. That was fantastic. And again, super practical, really useful. Lots of people in the chat saying thank you very much. So we have had some really good questions, so I'll try and get through a few. Some of them I think have been partially answered in the lectures anyway, so that's fantastic. Someone was asking, could they ask about what you do about, or what you think about rest days in between an exercise regime? And another person was asking how you kind of plan an exercise regime around their pain management plan.
I'll answer the first one, and maybe I'll let Kristen answer the pain one. And I'm sorry that I didn't include it, but Kristen sort of did with the plans, which is that typically we're asking dogs to do 2 to 3 formal sessions a week. In New York City, honestly, sometimes I just do once a week because it can be difficult to get to our facility. And then we're going to add home exercises so that they are exercising anywhere from 5 to 6 days a week. But minimum, you have to have at least 1 day of rest, if not 2 days of rest, where the dog determines what activity they do. You do not ask them to do anything beyond that. So definitely 1 to 2 days of rest per week.
Amazing. Someone actually also asked about if their exercise was going on a sniff-fari, so letting the dog go for a walk, but they do what they want to do. Would that count as their exercise, or would that count as a rest day?
I think that is more of a rest day because you're letting the dog do what they voluntarily choose. I do encourage that walks be purposeful, so you're moving the whole time. And while sniffing, I think, is a really important part of a walk for a dog, you might allow the dog to sniff a little bit and then you get going. And then we're going to move, and we're going to move, maybe it's for 5 minutes without stopping to sniff. And you can easily do that by moving the dog on the opposite side of where the fun sniffing stuff is. But yeah, purposeful walking is really important. If they're stopping and sniffing, I don't see that as meeting our exercise goals.
So different walks with different purposes.
Mm-hmm.
That's good. And Kristen, how would you usually plan it around a pain management plan?
Yeah, I mean, I think it depends on the individual dog. If they present and they are incredibly painful and really cannot do much in terms of their exercise, and they need some analgesia on board, I'm going to start certainly with a pain management protocol. Whether it's, most of my experience has been with NSAIDs as a first line, then usually putting amantadine as a second line. Nowadays, you could add in Librela if you wanted, instead of your NSAIDs based on your experience there. But then I'm going to start that exercise, the basic walking, just like Leilani mentioned, like starting where they're at. So getting them started doing something, just going for those very, very short walks as we're getting their pain management under control. And I think that no matter what we're choosing from an analgesic standpoint, I expect that pain relief to really start setting in within days to weeks. And then as we're rechecking them and they're improving, hopefully in their pain, we can start to gradually progress their walks, gradually add in, and we would start with some of those isometric exercises like Leilani talked about.
Brilliant, perfect, thank you.
I want to touch on a couple things that I see people wrote in the chat here, which is one that I love. Because I was saying that immobility is the enemy of arthritis. What I often say also is motion is the lotion. But yeah, you need to keep moving in order to, you need that lotion, you need that movement to maintain the mobility. A couple of people mentioned the importance of balance and proprioception and how on the human side that's been associated with morbidity and mortality. I couldn't agree more. I definitely see that in my canine patients, that ensuring that you're including balance and proprioception as part of their exercise program is perhaps one of the most important, even if they're not falling. Like you really need to include that to challenge their balance and proprioception. Another question about whether we should stabilize a dog with a sling or harness if they're very wobbly. Absolutely. And I think a good point about that is don't give up on not exercising a dog because they're having difficulty. Assist them as needed in order to accomplish an exercise, but only assist as needed. So as they're hopefully improving, we're using less and less assistance.
That was what I was going to ask next, so that's fantastic. Another interesting question from the chat, I suppose, again, because we've got lots of different people watching, I suppose it's talking more about how can we collaborate, and they were asking, can nurses or vet techs prescribe these exercises, or really should we be working with a veterinary physiotherapist?
I'll say what in my practice, what I would write in my notes was, what is the diagnosis? What are the goals? And what are our functional goals? So if I write, my goals are to improve elbow range of motion, improve core strength, improve shoulder stability. My nurses, I know the program that they've gone through, and they are trained that they know based on those goals, they know what exercises to choose. And so I don't have to be as prescriptive as do exactly this, because the nurses that I've worked with have been trained to know if these are our goals, here's all of the things that we could do and how to progress them that way. But Leilani, I mean, what's your experience?
Yeah, no, I completely agree. And what I would say is that it depends on the skill set of the technicians you have on staff, because the same for me, I have highly skilled. They're all rehab certified, and I'm writing a prescription much like an MD would write a prescription for a physical therapist, but that gives them lots of options, and they are definitely doing a mini assessment themselves that day in the patient and then choosing what's appropriate for the patient that day. I have a complete trust in my technicians. They are absolutely doing the exercise session without my direct supervision. They come to me if they need guidance. We always round at the end of the day to bring up anything that they're concerned about. But I think answering that question really depends on the skill set of the staff that you have. But is it possible? 100%. And I think a well-designed rehab facility is utilizing those technicians 100%. Doctor doing the evals and the technicians doing the treatments. I think that's the ideal setup.
Yeah, and I suppose if it's something that people are watching and they think, if our vet nurses are watching and they think, actually, that's something I want to get into, some great CE or CPD would be, well on the way to getting there. So I just want to, I think we'll draw it to a close there, but there were some really good questions. Thank you so much, Kristen and Leilani. It really was really useful. And like I say, all the practical information has gone down really well. Just to highlight to people, a couple of people in the chat have just put some sources of training. So it might be worth checking out those websites. The next talk is happening straight away. So if you would like to leave, go back into the lobby and join us back in the next link. It's going to be our last talk of the day. So it's going to be another really good one. It is on compassion, fatigue and empathy. So I'm sure there's going to be some really good lessons to learn and points to end on the symposium on. We'll see you there. Thank you again.
Bye.
And that is exactly what it's about. It's so exciting. Now, my finale, and these were actually some of the first people I contacted. This was a must. This was a must for me. This is the beautiful Sarah Fisher and the absolutely stunning Andrew Hale, who have influenced my journey so much. I wanted them to come and do the last talk of the day because I think with all of this new knowledge that you guys have taken on board, there are going to be some obstacles in the next few weeks and months. You're going to feel burden. You're going to struggle with putting knowledge into action. You're going to feel frustration. And that is unfortunately inevitable. But I wanted these guys to talk through how you can best manage it, how you can look after yourself. Because if we don't look after you, we don't have the ripple effect. We don't help the caregivers, and we don't therefore help the dogs and the cats and the animals in our care. So this talk is all about you, looking after you. And I'm going to step out and I'm going to leave these two beautiful souls to speak to you. Take care.
Well, thanks, Hannah. Hi, Sarah.
Hi, Andy. Thank you, Hannah.
Great. Well, what an amazing event. I've been dipping in and out over the last couple of days. So huge kudos to Hannah and the team for putting this together and shining such a powerful light on this. And it's a lovely way to end the kind of weekend, really, for me to share some space with my dear friend Sarah. and Sarah and I work in a very similar way. We try and work in a way that is trying to be representative of the individual dog that we see in front of us, the individual animal that we see in front of us, and trying to improve awareness there for the caregiver, and supporting the caregiver through all the different aspects of what that brings. We're going to touch on that a little bit as well, I think. But we really rely on working in a collaborative way with our colleagues, the clinical team, physios, the trainers. We create this care structure around the dogs and their caregivers. And actually, some of the things we're going to touch on tonight are the things that actually connect us all, not just because we're professionals, but because we're compassionate, caring human beings who work in a really tough sector. And one of the hardest things, I think, Sarah, is something I hear a lot, really. It's interesting considering we work in such a care sector, and we try and work in a very compassionate way, how hard it can be to even have self-compassion in the first place, how hard it can be to actually put some of our own needs up first. And I think that's something we're going to have a touch upon tonight. And we all have our physical and emotional safety needs and the supports that we need. And it really, truly does connect us all, because the caregiver obviously has their aspects that come along for them when they're caring for a dog who has either behavioral challenges or physical challenges, and the caregiver burden that comes from that, and the dynamics within their own social environment often. And then we have us as the professionals who we often turn up to the suffering of others on a regular basis. And in order to do that, I've got a human psychology background for those who aren't aware of that. And one of the kind of little rules that we have in human therapies is, in order to truly be available and to support another, we have to be in as a well-regulated place as we can be ourselves. And I think that's what we're going to touch upon tonight. So, Sarah, I think we wanted to look at these three words tonight because I think it ties up a lot of these different aspects: awareness, acknowledgement, and acceptance. And we're going to unpack those. And this is what we do with our clients, whether you're a veterinarian, a nurse, a trainer, behaviorist, whatever role you play, is that we're supporting the awareness of that person, the owner, the caregiver, in regards to their dog's physical or emotional experiences. We then have to support them once they are aware of the fact, for example, that their dog might be in pain, we need to support them to acknowledge that. And there could be all sorts of barriers. We're going to unpack all this stuff as we have a chat, but acknowledgement can be hard for some people, to their own defense mechanisms, their own biases, their own judgments. It can be tricky to truly acknowledge that. And then we move through then to acceptance, which is where we get those best outcomes, really, when we think about acceptance, especially because we know with humans that acceptance helps to unlock that more advocacy part of the brain. But I want us to start, Sarah, by really thinking about these three words in relation to ourselves: awareness of our own self, acknowledgement of our own challenges, our own needs, and acceptance of some of the things that we have to bear in mind when we work as a professional. And a lot of what I've learned around awareness, especially around observations, I've learned from you. And it's amazing how you pull together a lot of these threads. We were talking off air before about even your interest with children and that awareness, the awareness of the young brain and the young nervous system. So that might be a good place to start, I think.
Yeah, I think I've been very, very lucky. I run animal-centered education, but I never say that I'm the founder, because actually it's been created by amazing canine tutors, but also previous experiences. And I kind of came in to working with animals. I've always been obsessed by animals. Animals were an important part of my life from really early childhood. And I was really lucky that I grew up in a family that was really animal focused as well. So I learned from a really early age that we weren't to touch my aunt and uncle's Labrador on his left hip because he had arthritis in that left hip. And I did touch him on the left hip once and he growled at me. And my parents were really cross with me. And I totally accepted that it was my responsibility. The dog was never in question. The dog's behaviour was never in question. It was me as a child that had caused the disruption to this dog who was sleeping peacefully in his chair. And my paternal grandmother had rescue dogs. So again, I grew up knowing we couldn't look at them in the eye, that we weren't to try and touch them. So there was this acceptance that animals were very much a part of our family, and there was no expectation on them to behave in any other way than being totally honest. And as a child, when I was on holiday in Portugal with my family was sunbathing on the beach, but I was off exploring with the community dogs and exploring rock pools and the environment around me. And I have very rich memories from that time. And that no doubt has shaped animal-centered education in terms of observations and free work, that just joy at being in the company of these incredible animals. And I do look at dogs through ACE observations, through looking and sharing all the experiences I've had over many, many years. And one of the first things I say to people is ACE kind of comes with a health warning. You are going to no doubt feel guilty as we start to really look at the dog through new eyes, because we look at coat patterns. It was a dog in the care of the RSPCA called Sandy in the 1990s that totally opened my eyes to the changes that happen in the appearance of and texture of an animal's coat when there are changes to the structures beneath that glorious coat. And so as we start to sort of piece all these things together that we might start to recognize in our animal companions, feelings of guilt are absolutely going to come to the surface. Guilt that we may have missed something, guilt that we had a little niggling feeling but we didn't really follow through, guilt that we maybe overwalked our dogs that were painful because we might have had a belief that the amount of time we walk a dog is equal to the amount of love we have for a dog. And that is something a very dear friend has shared with me recently, that she now is living with that recognition that she was overwalking her senior dog because she really felt that that was a really important part of their relationship from the dog's perspective. And as we started to observe him moving in ACE free work, she was able to see that prolonged walks probably weren't the most beneficial part of their relationship together. And guilt means that we've learned something, and we can't learn without looking back and having some regret or, remorse perhaps. And I think it's really important that we really support people through that experience so that they actually feel safe. I want people to fall in love with seeing more and more detail in their animal companion, but I also want them to feel really safe in that experience. And I think that's something that you bring to the dog world, Andy. You help people feel safe navigating some really, really challenging situations and some, difficult areas of life with animals. And I think what Hannah's done with Cam is to bring so many people together. And I remember that early chat that Hannah and I had when Cam was in its infancy, and how I pulled over into a car park and just we talked for an hour and a half, sharing all this information about these small details that we can share with caregivers so they start to recognize these amazing beings and what support is available for them as a partnership, because that's what's of great interest to me, a partnership. And I came in through the human world, being a massage therapist for parents at Great Ormond Street Hospital who were facing the worst, and doing something that made me be able to connect with them in a way that I could just sort of hold that space for them. So huge love for animals from my early childhood, then in through the care profession for parents of children who are desperately ill at Great Ormond Street Hospital, and then back into working with animals. And I am passionate about having this collaborative, supportive community so that we can do the best for both the animals in our lives, best for ourselves, and best for the amazing partnerships that we're supporting.
I think that's where we have to look to those best outcomes, because a lot of the understanding on the clinical side of things, on the behavioral side of things, behavioral science. We're understanding how interconnected so many different things are. When we think about the complexities and the richness of an individual's lived experience, whether that's the dog or the human, it takes a multidiscipline approach. It takes many different people to come around to truly provide that support, that scaffolding, if you like, around some of these cases, and especially trying to support each other and our peers in this, and recognizing how challenging some of these things are. And I'm glad you mentioned about guilt, because if we think about awareness, whether we're trying to be more aware of our own lived experience or that of the dog or of the caregiver, when we come to the acknowledgement bit, that's often where guilt starts to come up, because and that can be, I think, guilt. We have to recognize guilt as a part of our growth.
Yeah.
Because it gives us a chance to look back. And there's just a couple of things I want to mention about guilt, because guilt can go one of two ways, really. First of all, if we keep allowing it to pull us back into the past, we can get chained to the past very easily, and it eats away at us then. I work a lot with clients who, when they become more aware of their dog's care and support needs, they realize, wow, why did I use that tool? Or why did I do that thing I saw the person on the telly do? Or why did I take that advice? And that's that thing about being chained to the past. But as you said, if we acknowledge the fact that actually that feeling, and a lot of this stuff, Sarah, is about us learning to change our relationship with things, including changing our relationship with our own feelings and our own experiences, not shutting them off or somehow invalidating them. It's like, I'm feeling something very deeply here. And guilt is a sign, a deep, visceral sign of learning. You've learned something really important. And by recognizing that and recognizing the choice that we can make moving forwards, it actually breaks that chain to the past. And it's a lot of a healthier way of looking at things. And I think, as I say, it's a part of our growth. And there's going to be many of the topics that have been covered in this conference, even for professionals who are like, wow, I didn't realize that, or I discredited that, or I hadn't taken into account of that. And we have to give ourselves, we have to be humble enough to recognize we're all on a growth journey and we're learning things, but mainly give ourselves grace to recognize, well, that was yesterday's Andy, this is today's Andy, and I have a choice about what tomorrow Andy might do.
I agree. And I think that's very crucial word. Feeling is very appropriate for us to consider all the time. Our feelings, obviously, but also how we disseminate information, or how we start to help people go on that amazing adventure of seeing more and more detail in the animal companion, and recognizing how much more of that story that animal sharing with them. And I don't always remember, I'm sure, and maybe I forget, or maybe use different words, but when people come to Tilly Farm, people that don't know me, we have a lovely farm and we run in-person workshops, and I also do online teaching where we're really looking at the dog's ear position, the tail position, the quality, texture of the coat, the movement patterns. We're looking to help dogs find a flow. We don't label movement as good or bad any more than we would label behavior as good or bad, but recognize that movement is the foundation for all behavior, because without movement, both voluntary and involuntary, life can't exist. So we're looking at that flow and that connection, and we set up enriching stations that are going to be enriching on a physical level for the dog as well, by getting the right height and angulation of foraging and licking opportunities. And we're discovering so many amazing patterns that all dogs from all ages and all backgrounds start to display, in terms of the length of that foraging or exploration experience tends to be around 17 minutes. They all do this amazing data gathering where they start to pick up information from unfamiliar people that are watching the sessions. And they've made me really rethink so many aspects of my life with dogs, that we can then take what we've learned from that free work experience into other areas of our dogs' lives. And when the individual has finished with their dog, I don't ask, or I try not to say, how do you think that was? Or how do you think that went? Or anything that involves them then having to go, oh, well, how does Sarah think it went? What answer is she looking for? I really try to say, how did you feel? How was that for you? How was that experience for you? How did it make you feel? And sometimes people will say, actually, it made me feel really guilty, because they start to observe their dog has got mobility and balance struggles. Or they might say, I actually felt unsafe because I've had to do so much micromanagement with my dog because of the behavioral link with chronic pain, that I actually felt uncomfortable initially letting my dog explore that environment. And if that person does feel unsafe, then obviously we say, please join your dog, support your dog, you're available to the dog's not totally on their own. But for some people, the act of just being with their dog rather than the act of doing something with or for or to their dog is a totally new experience. And if I ask them how they feel, that is their own unique experience. I can't influence that. And I think that's really important language to use, because it also helps people start connecting with how they feel. It's a very emotional experience, and I hope we create a very safe space for people. I certainly love teaching online, but teaching in-person workshops where we only have 5 dogs and no more than 10 people is one of the greatest things for me in my working life. I never tire of watching these amazing animals start to reorganize their body, and the connections deepening between the person and their amazing companion, the connection deepening in the animal's body, in the person's body, and connections deepening and strengthening within that environment. And we have amazing outcomes in this really peaceful, incredible, deeply enriching and rewarding way. But I really do try and be really mindful of the language we use, and to ask someone how they feel, I think is really important. And sometimes if you're going to be delivering news that might be uncomfortable or difficult or challenging, I support people going through human therapies as well. Still, we need to be careful that they are able to absorb that information and not throw everything at them, because if we say, how does that sound, or what do you think, we're separating from the impact that news or that new awareness might have on them as an individual. Does that make sense?
It does, and I think there's a bigger picture here from what you're saying, because just to lay a bit of a foundation, this is relevant to all of us, and it's really important. And I do emotional health workshops for trainers and behaviorists. I've had some vets come along as well, actually, because underneath all this is recognizing us as a sense of self, and how, as a society, how many of us are brought up and kind of indoctrinated really into this disconnection from self and the safety of feeling and what those feelings are and how we address those feelings. And a lot of the narratives we have in our head about self and our own belief systems have actually been put in there by others, by external experiences, by our trauma. So when we do connect in these situations, and I've seen this at Tilly Farm, where people get so emotional because it isn't actually about what they're being awareness of their dog, it's self-awareness that it's triggering for them.
Yeah.
And this is important, especially for those who work, I think definitely in veterinary and in our profession as well, who work in a very connective, empathetic way, because we have to work on self in order to be able to keep that balance right. Because it's important. The wonderful Brené Brown, Dr. Brené Brown says, empathy fuels connection. She also says sympathy drives disconnection, which I think is interesting, because what she's saying there is sympathy, there's actually often a little bit of a power imbalance with sympathy, because I'm like, well, I sympathize, but it's not happening to me. So there's a bit of a disconnection, whereas empathy is about connection. But we have to learn that we can be available to the emotional experience, the emotional truth, if you like, of another, but not be responsible for it. And recognize the responsibilities lies with our own emotional truth and the work we have to do to build that, actually. And that's why it's really important that we look at having more safe spaces to talk about these things. Inviting people to recognize the power within those safe spaces of being vulnerable. We spend a lot of time feeling vulnerable. My husband, he's an end of life nurse at a hospice, and a couple of things there. First of all, he gets involved with my work. I've got a lot of vet colleague friends as well, and he says he couldn't do any of our work. I think that's quite humbling, really, because he's got a tough job. But the one thing there, though, Sarah, is that he gets good supervision. Right. He gets clinical supervision, but he also gets personal supervision. And I think we have to find those spaces because we have to ensure. But when we think about compassion fatigue, for example, which I know is something that affects many of our professions, I think that's quite a good sign, actually, of the individual who's experiencing compassion fatigue, often struggling with self-compassion first.
Yeah.
Again, going back to Brené Brown, she talks about compassion and empathy. They can't be operated unless we have good self-esteem and good boundaries first, and we have to work on those and think about these things. And if you work within a culture, especially, and I hear this a lot from veterinary colleagues, I hear a lot from colleagues in rescue, where those who are creating the culture within those practices or those operations or those shelters are saying, well, you've got to be professional, don't get involved, don't get emotional, whatever it is that's being said, because of this notion of what professional means. The problem there is you will get involved, you will get emotional, but now you feel you can't talk about it. Yeah. So it's been an emotionally unsafe working culture has been created. So we need more discussion on this and to recognize that we have to have these outlets for us. We have to learn how we can be available to support others, but not feel we have to take on burden. And this is the darker side to empathy, actually. I think it's worth mentioning this because there's something called the writing reflex, which is an empathy plus the writing reflex literally sends people to war, right? Because empathy is like, oh, I feel your pain. But rather than thinking, okay, I feel your pain and I'm going to support you in a way that is best for you to find your ways through, the writing reflex can make you think, but I've got to put it right. I have to save, I have to do whatever. And that can be really tricky. And this is what leads often to burnout, of course, because we end up with that boom and bust cycle. A lot of my colleagues, our colleagues, we know them, Sarah, we speak to them. They're exhausted in rescue. They are exhausting. I'm sure it's the same in veterinary. But they keep turning up because they feel they have an obligation to that animal that they've made a connection with.
Absolutely. And it's really interesting when I have an amazing support group around me. I have an amazing supportive teaching team in ACE, many people who I've known for many, many years. We have a really, really lovely community. And I also have an amazing support system around me as an individual at Tilly Farm and within my own family as well, and with amazing colleagues, dear friend Sarah Heath, you know, so many amazing people. And I think that's really of such value because I can ask for help. I don't feel that it's just me. I wouldn't want it to just be me because if you're going to be responsible for someone's success, you're going to be responsible for their failure too. And we have to recognize that because some people do want to be the one that's responsible for someone's success or resolution. And that's actually, you know, a huge burden to carry. And it's not appropriate because to me, it's about being a part of a collaborative team that brings resolution or peace in whatever way that comes. But when we actually start to talk about this collaborative approach with people, some people are fearful of going to the vets with their animal, of enlisting the help of other professionals, such as a veterinary physiotherapist or something, and all the other amazing therapists that are out there, because as a child or maybe as a young adult, they had to problem solve on their own because their caregivers weren't available to them to help them resolve some of the emotional challenges they were facing as they were maturing. And again, that's why I'm so passionate about having a non-judgmental, safe space and this incredible network that Hannah's created and other people in the industry are creating, where we can direct people to go for advice and input that's beyond our knowledge, and have safe conversations where we can equally support each other and brainstorm as well. I do a lot with rescue. I'm a very proud ambassador of Battersea. It's rescue dogs that have absolutely been my greatest tutors ever. And I've had fosters and ended up keeping some of those fosters, and some of those foster youngsters really struggled in the world, and that then put an awfully big burden on me to not only support that animal, but also make sure the impact that animal had on the rest of my life and the other animals already in that space was not detrimental. And I've reached out and I've asked for other trainers to come in and caretake those animals in my absence, so that I wasn't the only driver of the dog's fun bus. I was able to extend that learning experience for those youngsters, and I wasn't going to put pressure on myself to be the only one that could support this animal, and therefore I had to say goodbye to other areas of my life that are deeply meaningful for me. So again, yeah, I'm passionate about this collaborative approach, and I could not work full-time in rescue. I love rescue. I'll always be involved in rescue. I'm passionate about rescue. I'm passionate about helping animals who are struggling, but people who are struggling as early as possible so their animals don't end up in rescue. But I take my hat off to anyone that's working in that environment every day, because it is getting harder and harder, because the expectation of people is changing. I don't know of people that had the same upbringing that I had. I don't, but friends of mine had rescue dogs. We weren't allowed in the kitchen as children. Then that was never anything we questioned. These animals were looked after, their safe space was created. There wasn't an expectation that these dogs should tolerate all this unwanted attention from children who wanted to connect with these animals, either in my own family or in the family of friends. And I just see that landscape has changed so much. There's such an expectation for dogs to be kind of bomb-proof, and that puts a terrible burden on trainers and behaviorists and anyone who's trying to help support that animal navigate their way through the pretty unpredictable and often very hostile human world.
Yeah, and it's a crazy time when we think about it, because on the one hand, we've never known more about the individual lived experience of the dog, pain, emotional, physical, mental, and yet the general public seem to have never been so detached from that information. Yeah. I'm glad you mentioned expectations, because I just want to touch on that a little bit, because again, I think it's relevant for us. Expectations really are about control. So if somebody has an expectation of me, there is an element of them wanting to control outcome or control my event. And equally, the expectations we put on ourselves are about us trying to control outcomes. And often a lot of those expectations, again, have been put into us from external narratives, trying to kind of get us to fit into some kind of conformist behavioral norm. A lot of these expectations come from. And I think if we are, for me, when I talk on some of my emotional health workshops, I ask a couple of very simple questions, but they're quite profound, really. And I think the first one is, who are you? Who are you as a person underneath all the layers of crap that we create and develop over time? Because from a very young age, our sense of self and identity is being informed by the language, as you said earlier, the words, the judgments, the expectations of others, whether that's that unhelpful school teacher who said you'd never be any good, insecure attachments at home, whatever it is. So actually it's quite a profound thing, and it's an important question for us to ask ourselves, and to reevaluate a lot of our belief systems and our value systems. But also, the second one is, who are you as a professional? Because the two things are connected a little bit. So I think if your self-esteem professionally and personally is low, and your boundaries therefore are quite porous. You mentioned a minute ago, one of the universal laws is everything we say yes to, we are saying no to something else. And if that no is our family, our dogs, our loved ones, or ourself, it's a problem, then it makes you more vulnerable to the expectations of others. And I see this a lot. I can talk on this with trainers who I support looking at some of these things on a one-to-one basis. But when we turn up, it's the same for veterinary. You have to feel quite well regulated, quite confident in your ability to do your work, open to hearing and being aware of the experience of that client in front of you, but being very sure about what it is that you can and can't do. Otherwise, you become vulnerable to those expectations, and you feel the need to somehow do more or change things, or kind of warp and keep warping yourself to fit. And that's that people pleasing mentality that we can fall into. And it's tricky. And as you say, even at somewhere like Battersea, which they do a great job there, of course, you have to protect yourself. Otherwise, you will take it all on. And it's not sustainable, I think. And if you're working in an environment, especially, God, I used to do behavioral clinics at local vets before COVID. I had the luxury of 20 minutes. I'd only do the most, maybe 5 at the most. I'd have a big intake form before I saw the dog. And I was exhausted. How our veterinary colleagues do 20, 30, whatever it is, consults in a day, bam, 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 with all those expectations, a stupidly small amount of time to try and do things. It's a huge amount. So we need more support, I think, for people to really work on self, so that we can keep turning up as ourselves. Otherwise, we're turning up as different versions of ourselves to try and fit all those expectations.
And I think it's important that, what can I do today? And I really, not tomorrow, not next week. Obviously we're all very busy and our schedules are jam-packed months ahead of time. But what I try and think about is being very much in the now, but being in the present. I want to be present for my amazing students who'll be turning up tomorrow, 5 new dogs, or some dogs that may be returning from having already done some workshops at the farm. I really want to be present. And I think it's so easy when we're living in our head that we don't recognize how fatigued we are. We don't recognize that we're not practicing self-care. We don't give ourselves time to prepare. And I always think about Atul Gawande, the amazing writer, and his checklist manifesto. And he looked outside of the health industry and looked at pilots, I think, to look at how they could actually reduce the number of deaths there were through error in the operating theatre. And he did a very profound huddle where everyone involved in the operating theatre, and I may be getting some of the detail wrong, so please correct me, anyone that may know Atul Gawande's work, but the huddle was turning up, saying who you were, what your role was, what the expected or hoped for outcome was going to be, and what might need to be put in place if something started to go wrong in that operating theatre. And this very powerful moment of connection as a team and acknowledgement of who you were and what your role was, he cut excess deaths by 47%. And that's really powerful. They ran it in, I think, 8 different countries, and then it's become part of the World Health Organization manifesto. And I think just that moment of being kind to ourselves, we're actually, through being kind to ourselves, we're more effective and kinder to others who we're going to meet through that day. And what I try and do, and again, doesn't always happen, is I try and sit for 10 minutes with my dog. I'm not doing anything else. I'm not on my iPad. I'm not on the phone. I'm not watching the world news. I'm not eating. I'm not sitting with a cup of coffee. I do all of that as well with him. But I try now and just have 10 minutes just sitting. And sometimes that might be before I leave and go up to the farm, or maybe at some point in the afternoon. I just sit, and he just sits, and he has this 10 minutes of just me, and I have the 10 minutes of just him. And it's been this really amazing experience, because he would always have an expectation of me still being busy, even when I was sitting down. And I needed to kind of relook at that for myself and also for him. And when I was sharing that tip with somebody who works with dogs for a living, this person said, "Oh, I haven't got time for that." And I didn't say anything. And then this person went, I actually can't believe I've just said that. If I can't find 10 minutes in a working day just to sit doing nothing, not sitting with my dog, chilling out, watching a movie together, sitting, doing nothing, just being in that space together, I need to reevaluate my work-life blend. And I would agree, this person would benefit from reevaluating their work-life blend. Sometimes I can't always do that, but I do my best to do that. And it's been really a really peaceful experience. And I just think about my breath, and I think about my heart rate, and I think about him, and I admire the rise and fall of that gorgeous abdomen and that amazing rib cage, and I watch him in deep sleep if that's where he's going and where the body twitches are coming from. Because interestingly, watching your dogs dreaming can give you really good insights into their mobility, because Henry's right ear is not as mobile as his left. He's got different ears from his different breed blends, but also he had restricted mobility through the right side of his neck and ear, and that's one of the reasons why he found life so difficult. And he's also got bilateral hip dysplasia, which is worse on the right, and I often see this correlation. And in his really deep sleep, dream states, the right ear doesn't twitch as much as the left. So I just love just watching him. And it's been a really wonderful experience. And I also teach people that come to ACE to count the resting respiration rate of their animal. And most dogs that I've had have had a resting respiration rate when they're in that real deep sleep of around sort of 8 breaths per minute. And that was hugely valuable for me. I'm really glad I invested time doing this with my animals, with our senior dog who we lost during COVID, because he was a senior dog. He had osteoarthritis. We adopted him when he was about 7. And I'm really pleased that when he passed at 14, there had not been any significant change to the osteoarthritis because of what we were able to do and put in place for him. But one evening he was lying next to me, and I just thought, I'm just going to do this check-in. And to my horror, the resting rate of respiration was 24 breaths per minute. And I knew he was in trouble. And he was. And I took him straight to the vet the next day. And those small moments of quiet are so valuable, because we can see and recognize so much. And obviously, the earlier we can find something, hopefully the better the prognosis, or the quicker we can make our animal more comfortable. And then we start to relieve ourselves of some of that guilt and regret that's an inevitable part of progress, as we've already discussed.
Well, it's a powerful reminder about being present. Reminds me actually of one of our neighbours who, she was just they were out having dinner. This is going back a couple of years, but she was, normally her and her husband, they've been married a long time, so you don't even look at each other. You know what it's like when you go out. But she just had a moment looking at her husband and then realised that he was starting to have the beginnings of a stroke right in front of her. She was just present in the moment, and I think so that's powerful. Also, I think a good point to remember here, I think, from what you're saying there, emotional health for me is no different to physical health. We have to work at it.
Yeah.
Healthy self-esteem, which is crucial as a foundation, it's not about high health esteem or good health self-esteem. I like the word healthy because it acknowledges that it's going to have its ups and downs, and I think we want to be in a position so that we can ride those ups and downs. And things come along. Sometimes we might have a tricky case, we might not have the most desired outcome, we might have trouble with online trolls, I don't know, the things that come along. And it's not that these things don't affect us. We can't not feel stuff, but it is about changing our relationship with these situations and improving our own emotional safety. So emotional safety has 2 really important parts. One is, for me, it has 2 important parts. The first is feeling safe to even feel, and recognize it's okay to feel stuff. And secondly, feeling safe to communicate that, and finding those safe spaces to be able to communicate that. It's very important. To say, many of us have gone most of our adult lives in situations where we haven't felt safe to even feel, let alone be able to communicate it. And we do have to have these periods of self-advocacy, And I think your little ritual, I have my own kind of daily grounding thing. This is my own thing that I do. So I like to listen to kind of orchestral music. That's my thing. So I'll always put something on that I feel the vibe for first. And then this is a good little tip. This is just something I do, but I think about my day and I always think about my husband first. And hopefully that gives me a nice feeling. Not every day, but if it doesn't, but this is, I love this kind of this memory map way of doing it, because if I think about my husband and I get a bit of a not so nice feel. I think, oh, something about that's happened today has made me a bit angry there. What is it? But anyway, normally husband good, dogs always good. That's great. But then I work through the day, and it's interesting when you think about it. You can often pinpoint the time of that day because you feel it in your tummy. You pinpoint that client, you pinpoint that word, you remember that thing. I think, right, that was the thing actually that's giving me that feeling. And then I often try and write it down, and I think I'll have to think about that tomorrow, because this way we're trying to feel stuff on a daily basis and acknowledge it, because what happens is the nervous system just keeps banking it. And then before you know it, you feel that you're in a complete burnout, shut down, overwhelmed, whatever it is. And it's hard to unpick, to think, what is it that started that process? What didn't I get relief for in that process? And that's where we need self-advocacy, especially if you're working for somebody else, thinking, actually, I didn't feel that I was heard there today, or I didn't feel that was a positive resolution. And these are things that we can think about working on. If we're not careful, if you imagine going around the supermarket, we just end up putting all the junk in the supermarket trolley. We're not putting the healthy stuff in. So it's no wonder then when we get back, we're just eating all the rubbish stuff. So we have to kind of work out how we do our kind of emotional shopping a little bit better.
Yeah, and I think as well, it's that how can we support their caregiver to be able to have that connection with self before they have that deep connection with their animal? Because what I've also learned is that we start to switch off our interoceptive system really early on. It's switched off for us through our upbringing, not through anybody meaning to override someone else's own personal experience. But again, going back to observation, someone handed me a puppy and said, oh, hold my puppy. My puppy's really confident. And I was like, I don't need to hold your puppy. Thank you very much. And this person said, oh, no, it's good for socialization. And it's not a checklist, obviously. And this puppy was kind of put into my arms, and the puppy did not go rigid. The puppy didn't wriggle. The puppy felt relaxed. The puppy's heart rate wasn't, pounding away in her chest. But what she was doing, she didn't send me. She air sent it back to her caregiver, her guardian, and I handed her straight back saying, she's looking for safety. She needs to go back to you. And I didn't want the person to feel bad or feel that they'd made an error, because they're quite an experienced dog person. And I started to pay real attention to this tiny language, this tiny, tiny body language that is information from the nervous system based on the sensations. And sensation is the causation for movement. And whether that being feels safe in that environment or not, or is worried or being, aroused by that sensation. And I started to pay attention to it in human babies. And my best friend's grandson lives at the farm, and when he was 6 months old, I was holding him. He could be upright, and they were all having supper. And I said, oh, I'll take him so you can all have your meal in peace. And he just started to lean this little shoulder to the door that goes out into the garden to my office. And I followed the lean, and he wanted to go into my office. At 6 months old, he was able to communicate that. And because I work with dogs with lots of sensory experiences, my office and my barns are fantastic places for small children, because I use a lot of stuff from sensory toys for kids in my work with dogs. So it's a great place for small children. He was absolutely able to indicate that. And then a bit later, I was flying home from, I can't remember, some European city, and this small child was on her mother's shoulders and kept pulling the mask on her mother's face, because it was during COVID where masks were still mandatory. And the father gave her her own mask and she dropped it and she was crying, and he picked it up again, and she was trying to sort of like look like she was stroking it against her face, but I could see what she was doing, but they couldn't, because they were so absorbed in trying to get the other children together and get their luggage and get on the plane. We were getting ready for boarding, and she was getting more and more frustrated, and she didn't want to hold the mask. She wanted to copy her mum and have the mask put on her face. And you could see how that frustration was building for her. And even though she was obviously non-verbal because she was so small, she was absolutely communicating. And I think we shut all this down, or it gets shut down for us. So we start to detach, and therefore we don't recognize in our companions when something's starting to change for them, when they're saying, I'm not sure, I need time to process, oh, I feel uncomfortable. And we kind of use language like, don't be silly, or that's a disproportionate reaction. And it isn't. Nothing's ever out of context as far as the nervous system's concerned. And I love what I do. I love the people in this industry, like Hannah and you, Andy, and Sarah Heath, and all my amazing friends and colleagues, because everyone collectively makes this such a beautiful, rich, kind, and safe place to be. And that can only be good news for dogs and cats and horses. And I just want to say as well, big shout out to all those vets during COVID. I might cry. Our dear old dog was put down during COVID. That's not why I feel emotional, because I have peace and acceptance about his passing. But my vet was not able to be with a family member who was dying because of COVID restrictions. And my vet went out of their way to facilitate the putting down of our dog peacefully, safely, while adhering to COVID restrictions. And this person did this for everyone. And I will always be thankful, and I will never forget what this person did for me and other people who lost their animals during that time, when this person couldn't even be with their own family member. And thank you. Thank you all for everything you do to help animals, and therefore the people that love them.
Nice. Poignant. Very poignant. The love in the chat is fab, which is exactly what we want. We want to end in a teamwork kind of collective endpoint. For me, I know that coming into the chronic pain sector, I think was emotionally very difficult. I think you've hit so many points: the guilt, the feelings of inadequacy, the feelings of not being heard, the feelings of not being heard leading to feelings of imposter, feelings of I'm not good enough, feelings of will I ever be good enough? And I think what I was really aware of over the weekend is that we've strategically chosen topics that are going to put some people feeling in their comfort zone, and the next one's going to terrify the hell out of them because they don't know anything about it. You know, they might be really great with surgical techniques, but they have absolutely no concept of the importance of sleep. So my fear for the weekend was that people were going to bounce into comfort, discomfort, terror, absolute bliss. So what I didn't want is for people to go away on the Sunday night feeling inadequate. I don't want anybody to leave this thinking that they're not good enough. You know, you might be well into your journey and you've got a support network and you're in a good place, but you might be really new in your journey. And I wanted you to take the wise words of wisdom from the lovely Sarah and the lovely Andy, that you need to have a support network. You really need to have safe spaces. The street dogs have come to see you, Sarah. Can you hear them?
I love it.
Oh yeah.
I'm on my way to go exploring.
Oh, I know, it's beautiful. But I do think that everybody who works in this sector, be kind to yourself. I think for me personally, I think the vet sector is getting there, but I think there's still a lot of people that put down the importance of this area, and it can make you really feel quite vulnerable, and it can make you feel a bit worthless. And I think it's such a growing, and it's such an important sector. I think the biggest, the slide that stood out for me all weekend was from Sheila Robertson when she was talking about how life is like a story. It needs a good ending. And I can't stress how important what our role is in that. Palliative care because unfortunately, osteoarthritis, chronic pain is often palliative care. We're not going to fix it. We've got to manage it. And it is our duty to make sure that that leads to a good ending. And whoever is involved in chronic pain management, hats off to you. We got a couple of questions, and then I'm going to get Paul to come in and thank the sponsors. And then I'm going to bring in the team that's been behind this weekend, so we can also thank you to them, because there's been a few people beavering away. So first of all, Kerry, you've been here all weekend. I've seen you. How do you get fellow caregivers to take an interest in their self-care? I find the least engagement with info on self-care versus patient care. So really, that's hard. Yeah. How do you do that?
I can just pop in on that very quickly. I think one thing is we can't make anybody do anything. Everything's an invitation. And I think this is where I think what we can do from my point of view is to try and turn up in a way that supports them feeling heard by us in the first place, because that's quite empowering for a lot of people, I think. And asking the right kind of questions to find, remember going through that awareness, acknowledgement, acceptance, finding those things that they can come to their own realizations of things. Even if you were employed as a direct therapist for that person, you can't make them change how they see things or feel, but we can create those little safe spaces for them and support them on whatever journey they're already on. And this comes back to expectations again. I think we have to just think, right, I'm going to turn up. This is the beautiful thing about compassion for me. We all have our own judgments, we all have our own belief systems, all this kind of stuff. But compassion is, regardless of how we feel, we're going to turn up anyway. And I'm going to help hold that space for you. And I think that's what we have to recognize, the limitations and the realities of what we can do when we try and support another person.
Yeah, I love that. There's a next one. We're going to tackle somebody that is obviously struggling to offer herself self-care. So Sarah Darling, she's been around for a while. I met her doing the CAM Advocate Level 1. She is extremely passionate about her work, and she demonstrates this in the question. And she says, I've just lost my way in knowing how to self-care. Any advice on how I can self-care? What's the first step? I think she's made it. I think that is the first step of acknowledging.
Absolutely, that's the first step, that acknowledgement, because we can all get busy, and then I've hurtled through life and I've packed quite a lot in, and I realise the more awareness of self I have, the kinder I am, and the recognise the need to self-pace better so I can be more present for each person I meet. Whereas if I'm kind of trying to do too much, I have to recognize, why do I need to stay busy? Why does my nervous system need to stay that activated all the time? What might I be running from when I think I might be running to something? And I think just giving yourself permission just to have these quiet moments. For me, it's that sitting 10 minutes doing nothing. I actually really enjoy driving. I have classic FM on. I love classical music. And I do a lot on Radio 4. I do a lot of thinking and learning when I'm driving. But that 10 minutes quiet time is really important. And sometimes I probably would have avoided that because of what voices might have started in my head. And then I also start to kind of think about this whole imposter syndrome thing. Do you know what? We should all be feeling it, because people that don't have that are probably not recognizing what they don't know. And I think we are actually all programmed to have imposter syndrome and to have anxiety. There's a biological necessity to have that, but we just need to make sure that it's not actually taking over our lives. And someone in my ACE group posted this great thing. They shared a video that they had filmed last June, and she'd taken like months to have the courage to put up a video of her free work session at home. And she said, I suffer from analysis paralysis. And I thought that was great, because it was a complete shift away from the emotions of, oh, I've got imposter syndrome, there's something wrong with me. No, there's something right with you if you have an element of imposter syndrome, because it keeps us humble and it keeps us learning. And if we're going to be in a position of teaching and helping, you know what? We have to be an even better student, and we certainly have to be a student of the dog. So just acknowledging that it's difficult for you is the first step. And then tiny moments. Don't sit for 10 minutes. Just say, can I do it for 30 seconds? Think about how would you support an animal that was struggling. You'd look for the smallest moment where they could find self-balance, where they could find emotional self-regulation. You'd support them in finding it for themselves. So be as kind to yourself as you would for any animal or person in your life. And that's how I think about what I can do to practice self-care and make sure I have time to plan the healthier meal choices, not rushing and grabbing and everything on the go all the time, and being available for myself. And it's not easy because we're programmed to care, and it can, be a very hectic world, and there's always pressures on our time, but we have to find time for self, even if it's only so we can be available for longer for others, because I don't want to retire. I don't want to give up, but I don't want to burn out either.
Well, just a button. Oh, sorry, just quickly, Andrew. One of the other intentions of the 3-day event was to show the breadth of knowledge that we try to achieve to work in this sector.
Yeah.
So we jumped from photobiomodulation to enrichment. We jumped from surgical consequences and how to avoid them through to postoperative pain syndrome. We've bounced around from so many different areas in the chronic pain field. I want people to realize what pressures we put upon ourselves to know a bit about everything and be good at everything and be able to provide for our caregivers in a very broad topic. So that intention was there to kind of go, it's okay. You can't know everything. Look how big it is. It's absolutely gigantic. So another kind of shout out to be kind to yourself.
Absolutely.
And no, I just wanted to throw a quick point in here because for many people, the reason they struggle with self-care, self-compassion, is because of their past traumas, because of their lack of secure attachments. There's a lot of things that we have to ask the questions why here. And quite often when we think about the resulting consequences of insecure attachments and trauma and our own kind of experiences through life, whatever it is, that we can either end up shutting ourselves away from situations or trying to become the saver, the caregiver, the whatever else. And I think that has to be looked at. And one thing I would say is I have a therapist myself who I have been seeing for the last 3 or 4 years, not because I particularly need to, it's because I choose to. And I think, I would highly recommend people to think about having that. If you're in our kind of job, if you can't find those safe spaces within your working practice and within your network, it's worth looking at it. So for me, it's tax deductible as well, and it's worth every penny. And I see her once a month, and sometimes we talk about nothing, sometimes we talk about everything. But I think we need to address some of these things so that we can connect to self, because ultimately, if you see your own worth as a human being, that has a huge knock-on effect then to kind of give you that shield to some of this other stuff, I think. But we have to recognize that for some people, it's harder because of those past traumas, because of those insecure attachments and those voices in our head, those narratives that are often fed in from others. It's good to throw. You're muted, Hannah.
Unmute. An epic fail right at the end. At least it was at the end. Come on, Paul, come and join us. Paul has been doing the logistics of the platform mammoth task. It's been gigantic. Look at him. He's a fraction of the man that he once was.
Disheveled. Yeah.
He's lost kilos in weight through cortisol levels. I'm hoping that I can get the rest of the team to join. Please come forward. The lovely Jade, the Joe, Blanca, Rachel, my colleague and awesome best mate, Harry. We're going to say thank you to the sponsors first. Well done, Paul. Well done, Paul.
Yeah, massive thank you to all the sponsors that have been involved. Quite simply, the event can't go ahead without these sponsors. They've been very generous, not just in obviously funding it, but in terms of producing content, helping us with speakers, There's a lot of work that obviously goes on in the background. So I want to say a massive thank you to everyone for being involved and for promoting it so far and wide. We've had thousands of people join us over the weekend, which has just been incredible. And a massive, massive thank you as well to all the speakers involved, particularly Andrew and Sarah there for a great last session to end on, and a big, big well done to Hannah for hosting so many talks and getting everything lined up.
Yeah, well, I'm going to do a massive shout out to Jo. I'm hoping she's going to join us. Social media Jo has just been at it for months. Her amazing, lovely assistant and friend of ours, Jana's been at it, so well done them. Blanca, we're hoping will join us. I'm really hoping she'll join us because she's been doing a huge amount of the graphic works, the video. Blanca!
Hello.
She has been behind the scenes doing so much work. Jo is here. Oh my God, this makes me super happy. I'm so proud of this incredible team that we've got. Jo is our social media guru. Blanca is doing all of the editing, loads and loads of presentations, loads of graphics. Legend. Rachel, I wouldn't actually be here without her. She has been my rock for months, bringing all of this together. Jade is new to our beautiful family team. She's been co-hosting for the weekend with me. Paul, brilliant mate now. I don't know how we've managed to do this, because it only was an idea in October.
It was the London Vet Show, wasn't it, that we met up and said, should we do this? Yeah, let's go ahead with it.
Let's do this. And I can't thank you enough. It's been wonderful. So do you want to add anything? Harry, do you want to add anything?
No, just I'd like to thank you to everyone who's turned up and who's joined us. It's been a pleasure seeing so many of you and for asking your questions and interacting in the chat box. Yeah, you've made this event what it has been.
Yeah, I do need to just thank this dude, seriously. Harry's my best mate. He's my project manager. He's been with Cam for about 18 months.
18 months, yeah.
Seriously, it's been a game changer, and he's put up with a lot of stress in the last few weeks, last few months. So thanks, Harry.
Welcome.
Right. Paul, do you want to see us out? And
tiny bit of housekeeping for everyone. So the actual event will remain open for the next few hours. I think where are we now? 10. So 8 more hours. The event platform will remain open. So particularly if you're in a different time zone and you've missed some of the earlier talks, you can head to the sessions area, catch up with anything you've missed. Once it closes down, the recordings will only be available to VIP ticket holders, and to access your VIP ticket, you go to the elearning.vet website, log in the top corner. I think about 75% of the recordings are up at the moment. I've been trying to get them all on today, but the rest will go on tomorrow. But there's hours and hours and hours of content for you to catch up on. They're available for the year, so enjoy.
Yeah, right. Come on, Andy. Final sentence. Just what's your feelings? Because you're like my emotional hot water bottle, you are.
Well, we wanted to go out with a bit of a virtual hug. And I think, there's way more that connects us, that divides us. We all have our own experiences about things, but I thought the more we can talk about our shared experiences, the more we can realize we're not alone with this stuff. And all our feelings are valid and all our experiences are too. So stay humble, keep growing, and give yourself grace, because we have to, right?
Aye. Well done. Thanks everybody for joining. See you next year.
Bye. See you later.